Good afternoon, everybody, and thank you for joining us on day two of our virtual Nurse Leader and Social Worker Conference. A big thank you to everybody. You all did a great job yesterday, making sure that you were interactive both in the sessions and with the exhibit hall, getting a lot of great feedback from our sponsors. So I really appreciate that. Please continue that today and round with everybody and click on those files, those videos and everything. Reminder at the end of the day that we are doing the grand prize for the iPad. So the more points you have, the more likely you are to win that, as well as doing the door prizes at the end of each break. A reminder that this is two separate sessions today. So if you are a social worker in here, we would love to have you, but you probably want to be in your session and not ours. So if you find yourself in that situation ever, and even if you're one of the nurse leaders and you accidentally click on the social worker section, just go back to click the back on the agenda and make sure you go into the correct session. All right, so starting off with something fun is our award ceremony for this year. I really want to start off with saying that being a nurse leader is so challenging in normal circumstances. So much of the clinical admin part of being at the sites falls on your shoulders, and we know that that's a lot. So just all of the great work that you all do each and every day is so impressive, and we're so thankful for it. But especially when you look in the lens of COVID and what you all have had to do the past, 9 months, or 6 months, however long it's been, it's been truly amazing. And we know it has not been easy. We know that everyone definitely has felt burnout or is still feeling burnout due to all that you all have endured. But know that it does not go unrecognized. You all have done a great job, and we really, really appreciate everything that you do, both for our patients, but for the staff, because it wouldn't be possible without you. So thank you again. All right, leading into the Nurse Leader Awards, we're going to start with promoting interoperability. So this is really doing a retrospective look back at 2019, and we're really looking at what the overall scores were for that. You all did an amazing job. We know that there was a little bit of a fire drill at the end of the reporting period because a lot of the metrics weren't pulling correctly, and everyone had to jump back in and fix things very, very quickly. But we met our goal. We got what we needed to get. We didn't take a reduction in Medicare reimbursement because of that, and we actually got a little bit more. So again, thank you so much for doing all that you did to make us successful. So starting into this, we want to talk about honorable mentions. Again, there was so much great work from you all. And so it just kind of killed us just to recognize one person, because we know so many people did great work in making sure that we were successful with it all. So to recognize our honorable mentions for promoting interoperability, we have Kelly Parker from Louisville Carrollton, Cynthia Riggs from Flower Mound, and Rachel Backel from Odessa. So each one of those individuals will receive a plaque just like this, recognizing all the great work that you did for promoting interoperability, both for your site and for the practice as a whole. So congratulations to those individuals. So the next award that we want to recognize is a special award, and that really is the Teamwork Award that made promoting interoperability possible and successful. And both Blake and Gina Foskey did an amazing job of both being in their sites at the time, but helping the practice as a whole. So we definitely want to recognize both of them, and both of those individuals. I don't know if you can see this. Well, we'll get this All-Star Teamwork Award for helping everybody during this time, on top of us still managing their sites. So thank you so much for that. And then our overall winner for 2019 for a performance award for promoting interoperability is Gina Foskey. So at the time, she was the nurse manager of Amarillo. Now she is our infection control and nurse educator, but during 2019, she did an amazing job, not only helping the practice, but also her site. So thank you so much, Gina. You will be receiving this award on top of a congratulatory gift card for being our top performer. All right, so moving into OCM. Again, OCM is another very important program that we have. So much of our our quality metrics tying to what we're doing through the oncology care model, and then translating now into Humana Cigna and soon to be United Healthcare. So starting with honorable mentions. Laura Schmidt in Waco, Jennifer Chrisman in Cedar Park, Marble Falls, Leslie Welch in Round Rock North and Georgetown, and Kim Peters in Weatherford and Granbury. Thank you so much for doing such a great job at your sites, keeping everybody on track, and all the great things you do, keeping your metrics up. And then our overall award winner for OCM is Laura Strite in our Mid-Cities market. So that's Bedford, Grapevine, and Keller, for anyone that doesn't know. Laura has many doctors, a lot of moving pieces, 3 full-time sites, and just looking at all the different components that she had to manage during this time, did a great job with that. So congratulations. All right, so this is a special award that after reading all the nominations, I couldn't help but making sure that couldn't help but make sure that we recognize our research peers. So I want to call out and I want to recognize an individual that truly is excelling in research nursing. And reading the comments and looking back over history, just want to recognize or have everybody remember how tough research truly is. You know, they kind of practice in the background, but all the knowledge, the FDA regulations, just the protocols and the endless reams of paper they have to read through to make sure that we're compliant and successful with our different research programs is impressive just in itself. But this individual really has stepped at the plate to not only mentor the research staff, but the research management staff, and has helped the network as a whole with the different things she's done. So I would like to recognize Tracy Messing, who is one of our regional research directors, as being an excellent leader or nurse leader in the advancements of research nursing. So congratulations, Tracy. I know she's not on the WebEx day because she's on PTO, but hopefully she sees this in playback, and she will definitely be getting this award later on. So congratulations. And then last but not least, the Regal Award in Excellence in Leadership. Again, a ton of nominations came through. I think we had almost 200 votes come in, but without a shadow of a doubt, the winner for this year is Loretta Mergerson from Salmons Cancer Center. She is the infusion room nurse manager for them, and she does excellent work with a monster of an infusion room, leads and organizes her staff very, very well, and does a great job. So congratulations. All right, so that wraps up our award ceremony. I know it was kind of fast and furious, but congratulations to all of our honorable mentions and all of our winners. You will be receiving this in the mail here very shortly, sometime next week. And we are going to end this session. And if you'll go out into the agenda and then pop into Holly's session, we're going to start with IQ. All right, thank you. All right, everybody, we are going to continue on, and I'm going to hand it over to Holly Books now to give us an update about IQ, the infusion scheduling software. And Holly, it's all yours.
All right, thank you, Lance. So IQ. So infusion scheduling has been just really a challenge since the beginning of time. Not only in our centers, but cancer centers throughout the country. And we've looked at multiple products, and we've actually done an unsuccessful pilot in one of these as well. So, this is an issue that has to be addressed to improve our chair management. You are all familiar with this slide showing you're all familiar with this slide showing peak chair use or the rush hour effect, where it's just crazy from 10 to 2 and then it dies out at the end of the day. This impacts the flow at our sites, as you know this better than anyone. The end result is patients are upset due to longer wait times for a chair. We risk safety and nursing satisfaction with overloaded schedules, and we look at expensive expansions without having a good system for proper chair utilization. So IQ has a platform that we feel will help solve some of these issues. The system takes our current practices and incorporates them into templates to help reduce the rush hour effect to a much more manageable day for our infusion room. So what is IQ? IQ is a cloud application that uses statistical algorithms to create optimized and predictive infusion scheduling templates. These are tailored for each center. So what does that mean? We know that Longview does not have the same infusion setup as El Paso or Salmons as Cedar Park. So this program will work with those variations so that we can account for those differences to devise a scheduling program that looks a little different for each center, but is still able to deliver reports and metrics to show what is happening in our infusion rooms. This is a copy of what the template looks like. It's segmented into 10-minute intervals and shows you the number of appointments for each start and duration time. At the top, you can see the duration buckets of 1, 2, 3 to 5, 6 to 8, and 9 plus. This is the length of treatment and will be templated to how many patients you can take with this duration time during your day. The developers work with each individual practice to make sure these templates really work for your practice. There's a number of different metrics you can see with this program. One of the ones that I like is the huddle calendar. You can visualize up to 4 weeks of future appointments at a time to see what's going to be your busy days and times. This will help you manage volumes proactively and really have a clearer snapshot of what your infusion center looks like in real time. Along with the huddle calendar is some of the other analytics on volumes and chair utilization. I know it's hard to see on this slide, but I hope you can appreciate how with this you will see in real time what's going on and to make improvements utilizing this information. We have been doing some pre-work on this, and we've been getting ready to implement this in some of our sites. This will be rolled out in waves. Wave 1 is coming soon. I don't have the official go live date yet for each of these waves, but we're hoping to see this happen before the end of the year if all goes well. Waves 3 and 4 will happen in 2021. IQ may not be needed at all sites. This really kind of depends on volume and the number of chairs, as there's a cost associated with this program. If your name is not on the list on the previous slide and you feel like this might be a good option for you, please let us work through these first couple of waves to see how this really works in real life. After that, we can start discussions with your ED on adding your site to the list. So stay tuned. We're really hopeful that this will help some of that 10 to 2 rush hour effect, and we'll let you guys know how the first waves go. Thank you. Turn it back over to you, Lance.
Awesome. Thank you so much, Holly. Doesn't look like there's any questions coming in from that. So we are going to go, if you'll go back out, and we're going to go immediately into Terry's presentation because we figured a lot of you will probably have questions about that, and we want to give her the full time to go over things and answer any questions you have. So you go out of this session and then go into Terry's session next. All right. Welcome back, everybody. So we are now going to move into value-based care updates and looking forward to the future with Terry. Terry, it's all on you now.
Thank you. Hello, everyone. I hope you're enjoying this virtual conference. So I've been asked to talk about pretty much the measures that matter. But before we go into measures that matter, we're going to start with some quick value-based care updates. So program updates. Some of you were cheered along by Dr. Wilfong yesterday about some of these program updates. So this may be not new to you, hopefully. So for the oncology care model, what's changed in the past year for OCM is that we've moved and selected for the two-sided risk as of July 2019. The pilot was extended for an extra year. So we now have a performance period 10 and 11. And this is mostly due to COVID. So any COVID-related episodes are going to be removed from the cost of care calculations. And our performance-based measures went down from 6 to 5. So basically, as most of you heard, everyone was doing well with our hospital admits, so the OCM1 has been removed. So the major focus moving forward for oncology care model is advanced care planning, hospice, utilization and reducing our emergency room visits. For Humana and Cigna, we finished our first year. We're starting the second year of the program. We are now getting daily inpatient census reports that we hope to have formatted and shared on SharePoint for you guys. We're kind of working through the kinks. I know we've been putting the Cigna census information out there for you to look at. We now have Humana, so that's coming to a SharePoint site near you soon. And then with Humana, as mentioned, we have the Innovent starting to introduce advanced care planning to the newly enrolled Humana patients to hopefully help us with that metric that we didn't do so well with. So the major focus is advanced care planning and reducing inpatient admits and ED visits. Are you starting to see a theme here? So for program updates, we have a new program starting the beginning of the year. Don't panic. It's a 5-year program. It's mandatory for selected practices within randomly selected zip code list. 13 of our Texas oncology sites are in that zip code list. You should already know who you are. It's a 90-day episode. Radiation Oncology Advanced Payment Model, or the ROAPM, is what's coming. So this is a 90-day episode of care. It's triggered by planning and treatment, and it's for traditional Medicare patients enrolled in Part B and eligible for Part A. And it's only for 16 of the cancer diagnoses. So this episode payment is pretty much a fee-for-service basis. But the difference between this and like the OCM program is that instead of paying the full amount, a percent is withheld and you have to earn it back with your quality measure performance. So the quality measures that they're looking at are pain and pain plan of care, depression screening and follow-up plans, advanced care planning, treatment summary communication, and a patient satisfaction survey. So again, are you starting to see a theme here with the measures that matter? In addition, we do have clinical and staging data that's going to be required to be reported. And here is your reveal of the 13 Texas oncology locations. El Paso is listed once, even though they have 2 locations in their market. All right, United Episode Care coming. This is an anticipated start date of December. It has a shared savings potential, and it's mostly a heavy lift for our revenue cycle team. So this isn't going to impact clinical operations as much as it's going to impact our revenue cycle operations. And it will be utilizing this new patient program screen, which I'll show you in a second. So Agilon also is starting soon. This is an Austin area physician group. It's a heavy lift for our advanced practice providers for capturing HCCs for the Agilon patient group. And we'll utilize this new patient program screen. So this is a patient program screen that has been added to the registration in Centricity Business. So this is a screen we're going to be using moving forward to track this patient program. So in the past, we were flipping insurance to value-based care, like an OCM FISC. We're not going to be flipping insurance anymore. So we're going to leave the insurance alone, and we're going to be registering patients via this patient program screen. So this screen has been designed to be used with task edits and reporting. So hopefully it will be embedded in part of our dashboards sometime in the future. Now we're still working with the technology team to fully understand what we can do with this and how we can fully utilize it, so more to come. Now, value-based care measures. How did we do? Remember this? This was from Dr. Will Fong's presentation. Again, this is the measures that go into our score, which determine how much of the shared savings we get to keep. So the list of programs with a shared savings or a payment adjustment are your OCM, the Humana, Cigna, United, the Radiation, and MIPS. So how much we earn depends on how well we do here. So things like MIPS, we're compared to others. If we do better than our competitors, we earn more of that neutral budget amount. With the radiation program that's starting next year, if we do well, we get to earn what they withheld back. With like Humana and Cigna and United and OCM, how well we do determines how much of that shared savings we get to take home. Okay, this is my string art program here. What this shows you are all the measures like pain, depression, patient satisfaction, hospital, EDs, hospice, imaging, treatment plans, pathways, advanced care planning, and which programs they're tied to. And you can see there's quite a bit. I mean, they overlap. So thank you to our contracting team for keeping the list contained and manageable so that we don't have to keep implementing new processes to meet the same measures for different programs. So hopefully you take away that these are the measures that matter. All right, depression screening and plans of care. What this is showing us is we've improved. Thank you. You guys have been amazing. We've gone from 40% up to, we're meeting goal of 86, sometimes as high as 90%. So well done. We have, at the time I created this slide, 14 of the locations were at 100%. So 56 of our locations are meeting goal or better. We are also meeting the goal for our Humana and Cigna programs. So well done. Thank you very much. We wanted to share with you this depression toolkit. So in addition to anything that we have posted on our SharePoint site, you can also go to the McKesson, McKesson's, forget it, My Oncology site. And there is this depression toolkit. And I believe you're going to get the slides or have access to the slides. And there is a link directly to this toolkit if you're interested in exploring it. It gives you how to use it as well as kind of a workflow and steps to follow. In addition to the wonderful help with Stephanie and the social workers that can help with this measure. Next, we have the pain assessment and pain plan of care. Again, fantastic job. We went from around 60% at the beginning, and we're now meeting goal of that 94% or better. So 13 locations were at 100%, 47 locations were meeting goal or better. Well done. Thank you. I know it's not easy. Monitoring and checking and nagging and going back and making sure that everything is documented where it needs to be documented. So we are meeting the goals for Humana, Cigna, and the OCM programs. Again, great work, lots of improvement. There is also a pain toolkit out there on the My Oncology workspace. If you're interested, the links here kind of goes through helpful sheets, helpful information. All of this is in addition to what we have posted on SharePoint. Hospital admissions. Here's where it's no longer the measure for OCM as far as a performance measure, but it definitely impacts cost of care. So we do have some top performing sites based on the PP6 data that has been shared. So Plano West had a 7% admission rate. So well done. Rowlett had 22%. So reach out to your fellow nurse managers at these locations to see what they're doing well. Humana, we had a 3% reduction in cost, not as good as what we were hoping for. In Cigna, we actually had a 13% increase in admissions from our baseline. Not very good. So hospital utilization, it's a total cost of care driver, and it is something that we need to work on and hopefully do better going forward. Again, we're, Dr. Wilfong used all his cheer references, and hopefully our navigating care can help in this area. So emergency room visits, we've kind of been flat from the beginning of the OCM program. For OCM2, the blue line represents the goal. We're above where we need to be, which is a bad thing in this case. So Irving, well done, top performing site with 11% based on the OCM PP6 data. Stone Oak was at 15% admit rates or ED visit rates. Southwest Fort Worth, great job, 17%. And then Grapevine, Bedford, you guys were at 18%. Again, reach out to these nurse managers, find out what it is that they are doing right to help in this program. So Humana, we saw a 6% reduction in costs, which was good. In Cigna, we saw a 22% reduction in visit, which is also very good. So the goal is to be 22% or less in order for our measures. So when we look at the avoidable diagnosis, when we stack them with our ED visits, which are in red, and the admits, which are in blue, you'll see the number one item is pain. So we keep coming back to pain and managing pain and why that's such an important thing to stay on top of. Followed by UTI, which I don't know what that means. It's just a placeholder. I don't know if that's pain or if that's something else. Nausea, vomiting and diarrhea, followed by dehydration, and then chemo side effects. So interesting enough, chemo side effects was the number one avoidable reason for hospital admits. All right, ED visits and hospitalization. There's also a toolkit for that. So you can go to the McKesson site and find this handy toolkit with a bunch of resources and suggestions for how to improve and manage this workflow. Hospice. Can't get away without showing this graph. Again, we all agree how important hospice utilization is. Again, we love to show how, when we have our patients on hospice for 3 or more days, they're passing away at home or in a hospice medical facility. When they're not on hospice or enrolled in hospice, 40% are passing away in the ICU or the hospital. So just can't express how important hospice enrollment and education, how impactful it can be, not only for our patients, but our patients' family. So hospice utilization, another thing that has been flat for us throughout this OCM program. The goal is the blue bar way up there. We've been flat. We've got to come up with ways to be better here, but we do have some top performing sites. Plano West again, with an 80% of their patients who passed away were on hospice for 3 or more days. Bedford, 73%. Round Rock was sitting at 70%. So well done, thank you. And reach out, find out what are they doing, what's working well for them in order to get these numbers. Humana, 28% of the patients were on hospice for 3 or more days. 17% were in the ICU within 2 weeks of death. 22% had chemo within 2 weeks of death. And only 40% of charts reviewed had the ACP discussions, documentation of discussions. And that's where that Innovent program is going to hopefully help us get up from 47 to 100%. So again, for hospice utilization, our goal is 63.8% or better. There's also a toolkit. You're seeing a theme here. So you can find it on my oncology workspace. There's a graph, a whole bunch of links for help and tools and playbooks and everything you can think of for your advanced care planning, hopefully to help in this area. Patient satisfaction surveys. So we kind of take a dip with the last performance period's results. So we were doing good, we were moving up. We are the blue line, if you can see that on this tiny little graph here. In all areas for access, effective communication, exchanging information, patient self-management, which is where the additional services fall, and shared decision making, everything went down from the last period measured to this period. So let's, kind of refocus on that. We have now the relation to patient survey, which isn't the same as this OCM survey. But Vanessa has created this fantastic dashboard. It's posted on the Operational Excellence site. And I just copied what Holly said in her email. So discuss this in your monthly quality committees. Your goals are for performance. If you're less than 4.3, you're building your performance. If you're 4.4 to 4.6, you're considered solid. And if you're 4.7 to 5, you're strong. So this will have the link to where you can find this on SharePoint. So our relation patient survey will be the same questions for that radiation oncology survey. From my understanding, it's the same set of questions. So that should help us for those sites who were in that zip code range. So where can you find your data? So Practice Insights, we have dashboards. You have your advanced care planning dashboard. They include an activity dashboard, eligibility dashboards, and performance measures. This is a great place to start. If you need help on how to use these, please reach out to me or Stephanie, and we're able to help you walk through it and utilize it to the best of your ability. And activity, this is where I've helped a few of you in the last month identify patients who have passed away, to do kind of a look back and a review. And again, keep in mind, it's only as good as your documentation. So as long as you document in the advanced care planning NOMED, in iKnowMed, then it should be pulling into these activity reports. Also on Practice Insights are your MIPS information. So this is where you can find depression and follow-up plans, pain assessment and plans, advanced care planning from a MIPS perspective. All those measures for those sites who are on the radiation oncology, those measures are these MIPS measures. And so if you're doing well now, you should be doing well for your radiation program. The oncology care model dashboards, you have your performance measures, which we're looking at the depression, the pain assessment, and pain plan of care. And if you aren't familiar with those dashboards, reach out to me. I'm happy to help you work through them and how to use them. On SharePoint, we have our OCM page, which we are revamping to value-based care. So be on the lookout for that. There is the PAPD folder, which is where we will put the claims-based data Excel files and PowerPoint files. I know I promised we would have that sooner. I'm trying to get better details. I'm failing at getting those better details, but I promise I'll post the patient detail files within the week. The Audit Resource Center has your weekly OCM 4 and 5 reports that Quisa has been pulling on Monday. Hopefully it's the same information that you would find on the performance measure dashboard for the oncology care model on Practice Insights. It's just pulled in a way that hopefully is a little bit easier for you to double click and find your patients. Humana and Cigna's daily inpatient reports will be there as well on the Audit Resource Center. And then Operational Excellence has your relation survey dashboard. So then we have our Centricity Informatics. We do have HCC dashboards. They're coming soon. They're not quite what we want yet, but we will be tweaking those as we go. They're kind of being reviewed by select people right now to see how useful they are. And this is where you can find where your data is. And thank you. Are there any questions?
All right. Thank you so much, Terry. So there were a few questions that came into the chat. Holly's been a champ in answering most of those, but we'll just kind of vocalize them for everybody. So one of the first ones was asking about the Innovent team and utilizing them for the advanced care planning talks. Are we looking at expanding that beyond Humana? And at this time, we're not, just because we have to see just the volume that we have to do, and the Innovate team truly is 2 people doing it. So right now we're sticking with just Humana, but if we find a need for it, then we will explore that option later on. Also, a question came about the revenue cycle people, specifically the revenue cycle supervisors. Do they know about the changes to United Healthcare? And that leadership team will be prepped, and they will help with the implementation on that side. So that definitely will be covered. A couple things that I did want to kind of hit on for everybody is that, pain was obviously a big thing that Terry talked about a lot during these slides. So really focus on how are we following up with these patients to make sure that we're keeping them out of the ER, we're controlling their pain appropriately. So utilizing Navigating Cancer, enrolling people into Health Tracker, or creating follow-up tasks if we know we're prescribing new pain medicine, or if you have somebody that's calling in about different issues that we're following up them, there's more frequent touch points, bringing them in if we need to for hydrations or antiemetics and those different things. Because when I look at those slides, pain, dehydration, nausea and vomiting, ketone side effects, most of those things we can handle in clinic if possible and keep them out of the ER, keep them out of the hospital. Another important thing to talk about again with these is ACP and that serious illness conversation program. I know we've talked about it a couple times, but really, if your sites are having trouble with it, that program is a really good way of advancing advanced care planning and making sure those conversations are happening and that we're getting that information that we need from the patients to really see what their goals and values are. My Choices, My Wishes has been around for a while now, and it's a good program, but I think the Serious Illness Conversation program does a better job of really diving in and kind of not confronting, but it's a very candid conversation with the patient and exploring their goals and wishes, but also giving a current state of what their real health situation is at that point. So if you have APPs or even nurses that are interested in your clinic about that, then make sure that you reach out to Stephanie Broussard and get that on the books, so that way you can get that going for your clinic. And one last thing about HCCs. So if you remember from Dr. Wilfong's talk, that HCCs, I think if every other patient gets one, then it potentially raises our performance-based payment by millions of dollars. So really focus on getting that message out to your providers and to your APPs that, during the treatment review and coordination or other things, that we're capturing those HCCs for those different patients, because we know that our patients are sick. They have a lot of comorbid conditions going on. And if we're able just to capture that in iNomed, then we will definitely have the tools that we need to be successful in these different programs. So a couple other questions have come in, so I'm just going to read those real quick. Kate was talking about OCM 4 and 5 reports. The last one is from 9/28. Is that still the most current one, Terry?
There should have been one posted for this week, but I haven't looked, so no. And if it's not updated on SharePoint, you can always go directly to Practice Insights. So the last time we did 2020 H1 might have been that report, but we should be seeing updated files for every Monday. So there should have been one, I don't know, what was Monday? The
12th.
Done the 12th. There should be one posted for the 12th.
Okay. Yeah, so we'll check back up on that one.
If not, yeah, we'll make sure it's up there. There'll definitely be one posted on Monday. So.
Okay, and that was kind of the same question Nicole had: is when are those pulled? So there should be one for Monday, but if it's not on there, we'll get it on there soon.
Right.
Linda, I'm sorry.
Right. The process for the ones on SharePoint that we're posting, we just pull it that Monday morning, and then do our magic and then post it. The reason why we're pulling it is because the leading zeros drop off if you just download them straight from Practice Insights. So if you're a site that doesn't really have a lot of leading zeros in your patient medical record numbers, you can go straight to Practice Insights OCM4 dashboard, and you might have more targeted, a smaller list that focuses only on your misses. And if you want help on how to do that, please reach out to me. I'm happy to do a team or a WebEx to walk you through it.
Okay. There was a question about relation, or I'm assuming it's a relation about the patient satisfaction report. Linda, I don't know if you meant the OCM report or the relation report. So a provider breakdown, I think, is available in relation, but it's through the actual system and not through the dashboard that we have on SharePoint. If you're asking about the OCM data, Terry, is there a provider-specific breakdown, or does it just tell us overall for the practice?
It's overall for the practice with the OCM patient satisfaction survey. If you remember, that's that 80 question survey, and it only goes out to like 120 patients of all of Texas Oncology. So it's not enough data points to be able to do it by site or by provider. It's only for the entire Texas Oncology practice.
Alrighty, so another question about the percentage complete reports being posted. Again, Terry, you said that those just get compiled every few weeks from Practice Insights. But if you're asking about the performance period reports, then those can be anywhere from a year to 18 months delay, depending on when Medicare gets the final claims in and they're able to compile all that data. Terry, correct me if I misspoke on any of that, though.
You've got it. I have not been updating those percent complete reports because that's kind of fading out. The performance measures are what matter. So that's that OCM 4 and 5. And then the claims-based data, that's that OCM, your hospital admits, your OCM 2 and OCM 3, that's the claims-based. So the claims-based, you can find that in the PAPD folders. The performance measures are found on Practice Insights, and those are real-time, claims-based. They have to run it out a year past the end of episodes, so that is that year-old data.
Okay, perfect. questions kind of slow down. So I'd be remiss if we didn't talk about huddles when we're talking about value-based care. So OC or not OCM, COVID has prevented probably in-person huddles from happening because you probably don't have the social distancing space to do that. But still, remember that there's a possibility for virtual huddles, either through conference calls, Zoom, WebEx, that sort of thing. As we progress through the year and into 2021, as much as I hate to say this phrase, COVID has become the new normal, and the different things that we have to keep in mind with the pandemic. We kind of have to get back to life as we had before COVID. So definitely start looking at huddles again, and what does that look like for your site, and how do you accomplish that with the new pandemic constraints? Because I think that does help, and I think those sites that do well with those different metrics probably hold some sort of huddle to keep everyone in the loop and how that's going for them. So if you haven't been holding them, then think about how do you restart that, and what does that look like for your site or your market. And then really the last thing is, with all this information, you guys are doing phenomenal work. I just cannot stress that enough. This is not easy in a normal time, and especially during 2020. It's just added complications to everything. And you guys are doing really well. But just continue to keep all that kind of in the forethought of how you're functioning day to day. Make sure you're going into SharePoint and looking in the OCM page at those hospital lists. I will tell you the Cigna list, the Cigna hospitalization list was kind of big. So there's a lot of patients in the hospital right now for a myriad of reasons, not just COVID or because of COVID, but still remember those reports are coming out. Like Terry said, the Humana report will start being posted as well. So that'll be another one that we'll have to keep track of as well moving forward.
Right. Our Cigna, that may have been why we had a 22% increase. It's not, we're working on it. Hopefully, when we get you the information you can use, maybe it's actionable, and hopefully you can take those steps to help keep this down.
Yes. Julie, you brought up for those sites in Dallas, Fort Worth, and Houston that utilize Revital. Remember that is a way that we can provide additional services to our patients to help show them and to different techniques to potentially help treat pain and keep them out of the ER. So thanks, Julie, for that call out.
Thank you.
All righty. Okay, well, it looks like the questions have slowed down. So I think what we'll do now is we'll take a break. And in between this time, please go and visit the exhibit hall, go interact with the different pharma booths, and then we will meet back here, I believe, at 1:45 to do leadership updates with Rhonda and myself. So yeah, take some time, go drink something, eat something, use a restroom, go to the exhibit hall, and then we will see you back here in, about 45 minutes. All right, thank you, everybody. All right, welcome back, everybody. So before we get going on the next segment, we're going to announce the door prize winners, which are, or who are, sorry, Veronica Laura. You have won the Apple AirPods, and Carrie Lewis, you won an 8-inch Echo Show, so congratulations. All right, so we are going to go right into nursing leadership updates with Rhonda Boren.
Thanks, Lance. Happy Friday, everybody. Thanks for joining us again. This afternoon, we wanted to talk to you guys about the RN residency. We're going to talk about the ONS vouchers and talk about new nurse leader onboarding as well as staff nursing onboarding. So we'll get started first and we'll talk about the RN residency. First of all, I wanted to thank you guys for those of you that have done the residency previously with us. Thank you for continuing to support us and to help us to find good mentors and preceptors for these groups and being supportive of all of our questions, our emails, our follow-ups. So we do really appreciate you guys continuing to support us with that. First of all, I wanted to recap for those of you who may be new to Texas Oncology or are not sure about how the program works. I wanted to talk about the program, some of the background work, some of the current work we do, what happens during the residency itself, and then what happens after. So first, we have 2 cohorts each year. Typically, those fall in February and in July. The talent acquisition team posts these residencies for us. They conduct the phone screens, they look at the resumes, and then they are sent to myself and to Lance for review. So those final interviews are generally, we do 15 to 20 people in person as far as interviews or virtual in our new COVID world. And then our final selection has ranged anywhere from 4 to 6 residents. For final selection. And a little bit about the residency is why it was created. Lance created this program prior to myself working with him on this team. And he really identified there is a huge need for our nurses who are aging and who want to retire. We also have seen there's a huge decrease in oncology experienced nurses in the market out there. And so there is a need for us to really try to grow our own and to use that opportunity to take in new nurses. I know I've been there as myself. It's not always an ideal situation, but we have found that this has been successful so far. Takes a little bit of extra legwork, but it's helping to put more folks into our group of nurses, and hopefully that will stay with us long term. So a little bit about the classroom training. The classroom training itself typically is held at the Proton Center in Irving or Las Colinas area. This past time, we did do the cohort virtually. We had 3 days that we actually met in person. The rest of it was done completely online, but it's 2 weeks overall. During this classroom training time, those new nurses are assigned all of the Phase 1 ONS courses. They do attend new employee orientation. They complete their safety compliance. We do request and get all of their logins for Inomed, Centricity, anything that we use within the network. We get their logins created for that. And what we do is we tie those logins to where they're going to be precepting. They complete the fundamentals, the 101 on learning on the Learning Center. And then we have various Texas Oncology departments and leaders that come and talk to them about programs. So we've got Sarah Toth comes and talks to them. We have one of our nurses from Austin, the Austin area, that comes and does a nice review over IV therapy and port access. We have, trying to think, we have other leaders that come through, and pharma as well, to go over with these nurses. We do breast cancer, lung cancer, colon cancer, and multiple myeloma overviews for the group during lunches. So we have the pharma, either nurse educators or the pharma reps come in and do those with them. They also have presentations that they do. It's similar to when they're in nursing school and they have their case studies or their preps that they do before they take their patient assignments. But we give them several non-chemo drugs and chemo drugs. And we ask them to present to us. It's very informal, but we ask them to present what type of drug is it, How long do you give it? Talk about the nursing considerations and anything that's unusual or distinct about those drugs. And we talk about them as a group. We give them feedback. Of course, we expect that they don't know everything on these drugs, but we have found that if we hit some of these items that we see a lot in the clinics, they're at least familiar and have seen the drug names and can have some expectation of understanding how to give those drugs when they get to the clinics. And then I did talk about the pharma education as well. This is just more about the classroom training. I spoke before. We do have the different departments that come in from Texas Oncology, the Port IV demo and education. And just to make sure you guys all understand, it's pretty limited on hands-on IV and port skills. The presentation's great, but it talks to them more about how to select a vein, how to access the port. We have demos that we have from the pharma company, not the pharma company, but the company that creates these. It's Bard. And the nurses, we give them a Huber needle and we let them practice understanding the angles and things like that when they're accessing ports. We do about a half day on SharePoint. We really want them to understand that SharePoint is very important for our nursing staff, especially our Texas Oncology nursing page. We show them where the policies and procedures are, where consent forms are, anything that's on our nursing page. Mandy Hodge usually meets with them and goes over this information. And then she also does a high-level overview of SharePoint in general. So she teaches them how to search and find different policies, procedures that aren't necessarily related to nursing. And it's usually very interactive, and they appreciate that as well. We do a Navigating Cancer demo. The Navigating Cancer demo has grown over time as we've continued to add more things to our platforms that we're using. So we initially started this with just triage. Now with this next group, we will also integrate Health Tracker. We teach them, we give them a test patient, we have them create a triage ticket. We teach them to create the follow-up task, and then we will integrate Health Tracker into this next group, and we'll show them that as well. We do go over clinical policies. All of the residents are given an RN binder. So for those of you that have had residents come to your sites, in Precept, you'll see it's a huge three-inch binder we give to them. And in that binder, there's everything from the admixture guidelines, clinical policies that are very important. We give them the cheat sheet on the acuities and the acuity times and scheduling. And just a lot of good basic information. A lot of times what I've heard from feedback from the residents is they'll take and pare this down when they get into the clinic with their mentor after the residency is done, and they still find this to be a really useful tool. But if anyone is interested in seeing more about that, I'm happy to share it with you. Just let me know. And they do have a half day spent on iKnowMed basic user training. It is geared towards infusion. We have had all but 2 of our residents have been placed into the infusion room. And so most of the training goes in that direction. And we will be working with this next group. Will depending on who is part of the residency, we'll see about looking at G2 versus G1 training, because we'll be kind of in flux. It'll probably be mostly G1 training. So we'll take a look at that and see. So when they complete the 2 weeks of classroom training, then that's when they go into their 6 weeks with the preceptor. And this is very, very vital. And I really feel strongly that behind every great nurse is a great preceptor. I was brought in and worked with Texas Oncology myself as a new nurse, and I had great preceptors. They did a wonderful job. And so that's why this is super important to me. And I want to just talk a little bit about what we're looking for with our preceptors and what that training looks like. The training is one-on-one with the preceptor. Our preference is that when we choose the preceptor, unless there's something that Lance or I know about ahead of time, that these preceptors work pretty much individually. Of course, we all know there are opportunities to learn from others, but we want to try to keep the teaching and learning consistent. The preceptors are interviewed. And last time we did virtual interviews with these folks, they do get a bonus at the end of the residency. It's $1,200 total, which comes out to be $200 a week for those 6 weeks that they're precepting with that new nurse. We do have these preceptors sign contracts with Lance on the expectations. It talks about our culture compact, how we want them to definitely push these new nurses, but with a level of transparency and honesty to, help them, push them, but in a good culture, in a way that they're learning and they don't feel like they're being beat down because they're asking questions. We want them to ask questions. We want them to learn, but I do tell them to be expected to be challenged by your preceptors. And for those folks that I talk to about being preceptors, I really ask them, figure out how your resident learns and how you like to teach, as everybody does that differently, and really push those folks in that direction and work well with them. I also do weekly check-ins with the nurse and or Gina. Gina will be integrating in this, and I'll talk about that at the end too. But we do weekly check-ins with our preceptors and our residents. We're just trying to get a pulse on how are they doing. We have had some instances where, people are getting very stressed out over IV access. That's usually the biggest complaint. They have very little to no training in school, and then we aren't able to give them a lot of training in the precepting and as far as the classroom training. So this 6 weeks, they find a lot of their skills, and we try to remind them to give themselves the grace to understand they don't know it all, they can't do it all, but they just need to build on it on a day-by-day basis. And that's what those weekly check-ins are for. And if there's something that is major going on, we can go out to the site. We can be there to help them. We are still definitely a resource for your teams if you're doing any precepting. And then this is when they're going to begin their skills validation checklist. So in that residency binder, they do have those skills validation checklists, and we just ask that the preceptors start to work with those new nurses and focus on the things that you do a lot of. Get the most bang for your buck with these folks, and show them what we do a lot of, get them comfortable with it, and then day by day start growing on what they can do in the clinic. So what happens after the residency is finished? So around the 3rd to 4th week of the actual training for the 6 weeks at the end, myself, Gina, and Lance, we work with the resident and a talent acquisition team to see what current openings you guys have out there. These new nurses, they do have to interview for these positions, although they're a Texas Oncology employee from the beginning. And they work under our operational excellence budget for those first 8 weeks. We will be working with them to find those new positions. Some things to keep in mind is if you have a practice that you feel like is a good culture for a new nurse. Not every clinic is at the spot where they can take a new resident or a new nurse after precepting. So really think about that when you have openings, and it's not going to hurt anyone's feelings. If you tell us you don't feel like this nurse will fit, we want them to stay. We want them in an environment that's going to grow. They're going to grow and prosper. So Lance and I do ask that, when we're reaching out to you guys and we're trying to find placement, be really transparent with us. And some of you have, and we appreciate that, about whether you think this person would or wouldn't fit into the positions. At this point, we haven't had any issue placing our residents. One cohort, Lance had a couple of them that he had a week or so additionally past the residency, but they were able to fill in some needed spots until they found a permanent home. And so that worked out well. They also get a post-residency survey. The residents get a survey to evaluate their preceptor, and then the preceptor gets one to evaluate their resident as well. And that's important to us so we can make sure we think we have great preceptors, but were they really? And that we think we're hiring in really good residents, are they really? So that's what we need to hear back from you guys. And then we track the residents online through Workday at the 6-month, 12-month, 18-month, and 24-month marked for attrition to see how long they're staying with the company, hopefully much longer. So here is just the retention from the cohorts that we've had so far. So the first one was the winter of 2019. There were 6 residents. Unfortunately, 5 of them have left since then. Summer of 2019, that's the second one. We did 4 residents, and 1 had just recently left Texas Oncology. Winter 2020, we had 4 residents. They're all still with Texas Oncology. And then summer 2020, we did 6. And they were all placed in September. To note with this last residency, we did have, sorry about that. We were able to extend this cohort beyond DFW, so we are excited about that. Holly talked a little bit yesterday about we're really trying to do that, and we really are. So Janet Mullins and Austin Central held one of our residents. It was very successful to this point. I think everything went very well. What she did was, since we were virtual, she only had to come up to Dallas for 3 days, and we did cover her mileage and her hotel, things like that, under our budget. And that's what we would do. We're currently looking at some other options for future cohorts, but at this point, we are still actively looking for other regions, and we're posting it throughout the state. We hope to continue to do that. And as Gina gets onboarded more into her nurse educator role, we hope to expand this. So just more to come on that. But I just wanted to give you guys an idea of what those first 4 cohorts look like. We'll be posting our cohort number 5 actually the first week of November. We just worked on that this week. So I'll be sending out an email to all of you guys in case there is anyone that you might know that is interested in applying for the position. And that cohort is actually going to start most likely the latter part of January, trying to fit that in before our El Paso and West go live with G2. That's all I had for the that's all I had for the RN residency. I'm going to move on to the vouchers, and if we have questions and such, we'll have some time at the end. So please feel free to ask questions as you guys see fit. So with the ONS vouchers, just wanted to talk a little bit about the process of selecting the vouchers and how to get them assigned for your staff. So we're working diligently, and thank all of you who have answered my emails and had sent in questions to me. And I appreciate you guys being patient on some of these questions we've had, but we're working to make sure our tracking is working correctly with these vouchers. So first of all, as far as selecting the vouchers, there is you have to use the Learning Center as well. So what we have found is when you go onto SharePoint and you request your voucher, then you're going to get that acknowledgement that here is your voucher code. So the clinical leadership team will give you that voucher code, and then the nurse manager or nurse supervisor will get that after they've requested it on SharePoint. Please do have a discussion with your staff member that you're assigning this course to them on the Learning Center. And then when you do request it on the Learning Center, please give them an expiration date. Think about your clinic, think about what your expectation is, and make it as quick a turnaround time as you can. Some of these classes are a little lengthy, but most of them shouldn't take more than a few weeks to a month, depending on what kind of time you're going to be able to supply for that nurse to finish the course. Any first-time users that don't have an account with ONS, you can create a free ONS account and do that as well. And then when they complete the course, they need to make sure they mark the course complete in the Learning Center, and that they also do the evaluations that are on the ONS website. And then the manager or supervisor needs to keep a copy of that completion certificate or evaluation in your HR files for their records. The one caveat to that, you guys, is just remember as well when you're talking to your staff members, ask them to only access these courses on the Learning Center. Please don't go directly to ONS's website. We think that that's part of the problem with some of our tracking, is that it needs to be accessed always through the Learning Center, not directly with ONS. And then finally, if you'll just request for one voucher at a time, we are pretty limited on what we have available in general, but we're definitely low now because we're coming to the end of the year. So please definitely do request them. I'll let you know if I don't have the classes available, but just request one at a time. And we expect to get more vouchers hopefully next year, more to come on that. I don't have a definitive answer yet. And if our process will remain the same, I don't know. But as soon as I know, you guys will know. So the biggest piece with this is just be sure to please make sure you assign it on the Learning Center after you get the approval. Have that conversation with your staff member and make sure everything gets marked completed on ONS's website, on the Learning Center, and that will close the loop on that. Here's just some utilization of the courses. So you guys have done a really, really good job with this. For phase 1, those phase 1 courses, we've issued 472 vouchers. And for phase 2, we've issued 121 vouchers. So that's a really good job. And I wanted to talk a little bit about the difference in the courses real quick too. So phase one are your new nurses that are a new nurse in general, or a new nurse to oncology, or it could be a nurse that's worked in oncology 10 years ago and they're coming back to the field. Those are the courses you want to take. We want to ensure, Lance and I really want to make sure that all of our nurses that are giving infusion have their chemotherapy biotherapy provider card. And just remember, if we're out of vouchers for those classes, that they still can take the class under their professional development, because it's very important that our nurses have those. For the phase two courses, the first 4 courses are a bundle of sorts. If your nurse is planning to use a free take for OCN, or if they're going to be taking their OCN under professional development, we want to strongly encourage your nurses to take those 4 classes to help prepare for the OCN. We have seen a large percentage of nurses who do take those classes pass the OCN the first time. And if you don't pass the OCN the first time, then that's what's going to be asked next anyway, is that you complete those 4 classes before you do your retake. So just keep that in mind. We went through this already, the key takeaways: assign in Learning Center, give the staff a deadline, mark it complete in the Learning Center, and then make sure you have a copy of that completion certificate in the employee file. We talked a little bit about courses for 2021. There's more to come on that. As soon as we know, you guys will know, and we'll hold the questions until the end. And then the last piece I wanted to talk about was a little bit about new nurse leader onboarding, and just in general nurse onboarding. So this is just a screenshot. If you haven't seen it, this is thank you to the NEC who helped me look at this and give me some feedback. This was an onboarding plan for a new nurse manager or nurse supervisor. And we looked through this, we've talked over some things, and we've put this out onto SharePoint and the onboarding material for new nurse leaders. Lance also created, that's just next to this on SharePoint, a daily, weekly, monthly, quarterly spreadsheet of recommendations of things to help new nurse leaders, supervisors, or managers stay focused and organized. We all know there's a lot of tasks you guys have to do, and sometimes you can get a little bit distracted by all of the demands of what do I need to do next and which ball is most important. So this kind of helps. So if you are on this call today and you're a new leader and you haven't seen this, please take a look at it, talk with your PA, PD, make sure you understand what your roles and responsibilities are. It does vary a bit. These aren't all encompassing. Every site's a little bit different. This is just a large overview and suggestion for nurse leaders. And if you are a nurse leader and you haven't talked to me and you would like some more onboarding time or training, please talk to your PA, PD. You guys can reach out to me and we can set up some time to either meet virtually, or depending on your site and space, I can come to your site as well. I'm happy to help anybody that has any questions with any of their onboarding needs. We can do that. And this is for your new nurse leaders, managers, and or supervisors. Those are the only presentations that I have, but the other piece I wanted to talk about is more of our regular staff nursing. So beyond the nurse leaders, I wanted to kind of give you guys some information about a Survey Monkey we sent out. I think it was in July or August. We sent it out to, it went out to about just over 300 nurses who have been with Texas Oncology for less than a year. And we were asking them feedback. So, we asked them just a very few questions, strategic questions that we thought we knew answers to, we wanted to verify. And overwhelmingly, the responses were they felt a lack of formal training for INOMED, for centricity, for navigating cancer, specifically INOMED and centricity. But they spoke a lot to just not having any formal training time to all of that they would call the systems that we use. So we had about 70 responses from the 300 that we sent it out to. That was the most common complaint. The second was, and this was obviously geared towards infusion, is they didn't feel comfortable with the medications and the amount of medications that they were required to know and comfortable giving those, as well as coverage in other areas, specifically around who does what. So who's the revenue cycle team? What do they do? Is it the PBR? Is it the clinical reviewer? Things that was another common complaint from a report, I guess, from those new nurses. But overwhelmingly, it was iNomed. And so we got to talking about what can we do better, right? And so we really want to shift our focus this year on making our onboarding better for our nurses. And myself and Gina have been working really hard on some of our onboarding material. You'll see if you go onto SharePoint as we update through our onboarding list of items, there are some new things there we have already updated. And by the end of the year, we should have all of that material updated. So please take a look at the onboarding material if you haven't. It's really good. It's updated. There were some things in there that Gina and I have gone through, changed some timelines. And the thing I found most interesting myself personally when I looked through it is if you'll notice on an onboarding guideline for an infusion nurse, if you're looking at this particular guideline, it shows the infusion nurse not giving any chemo for the first 3 weeks. And I love that. And I know you're thinking it's crazy, it's impossible because your clinics are busy, but also think about your retention of that nurse who's frustrated because they didn't get the time to learn the systems. So be sure, take a look at some of those guidelines. Make sure your new nurses have time in clinic to do these ONS classes. Gina and I are working on some iNomed G1 training. We know that G2 is out there as well, and we're going to have more modules and more to come on that. If you, centricity training, we did verify this week that we're working with the revenue cycle team to create a regular cadence of centricity business training that's going to be happening monthly, that's going to just focus high level for nurses and MAs. And then with Navigating Cancer, you have all the tools on their website for training. You have them, I think Lance has put most, if not all of those same tools on our Texas Oncology Nursing website as well. So think about those things. Make sure your nurses have watched the triage video. Make sure they've done the health tracker videos and try to give them time to learn these systems and be comfortable with that before we're putting them out into the clinic to shadow. It was definitely an overwhelming report. And they did say, too, that the last thing was that they felt like their assigned mentor or trainer didn't want to train them. They didn't get good feedback. There were even some reports of some angry mentors or preceptors that they just felt as a bother. Something to consider is talking with your PA, PDs. If you have really good mentors in your market that you're using, see about how they feel about doing a spot bonus. And if you have more than one good mentor, rotate them. Try not to go to the same person all the time. They do seem to get burned out over that. And so those couple of things might be some good suggestions for you guys. We're always open to learning more. As far as educating, we want to make our teams better. I feel like with G2, we're going to have some good platforms for training. So for those of you who have G2 coming soon, when you're hiring your new nurses, make sure they do those modules on the Learning Center. And if you just run out of bandwidth, you just don't have the time, reach out to myself, reach out to Lance or Gina, and we can be resources to help train folks too if we need to. We just want to make sure your teams are getting what they need before they get into the clinic and taking care of these folks. And I think that's all I have. Lance, did you want to jump in here?
All right, thanks, Rhonda. Thanks for all of those great feedback or that great update from our nursing leadership. So there are a few questions on here that I would like to address and make sure we talk about these. So the very first thing is the RN residency binder. We'll make sure we post that on SharePoint. I think that's perfectly acceptable to be open to everybody. All the materials that we pulled are on SharePoint anyway. We just have it consolidated into a binder-like setup. So I will make sure that is shared after this week on SharePoint, and I'll send out an email to everybody. So about the residency itself, and specifically asking about the retention and why people left, it was a myriad of reasons. And just to kind of go through some of those, one of them, unfortunately, was bullying. That the resident was most likely bullied by the senior staff, which is not unheard of in healthcare, but definitely not something we want to see in our site. So, if you do get an RN resident or even a newer or newish nurse, make sure that you set up an environment that is conducive to learning and to be supportive. The old adage of eating our young still is present in healthcare, unfortunately, and nursing is not immune to that. So, we want to make sure we're not losing people due to that. We were all new once, and we weren't born with the knowledge of being a great nurse and being a great oncology nurse. So making sure that we're just setting up an environment that fosters their growth and makes them want to stay with us, which sometimes can be difficult. I mean, sometimes a clinic is just chaotic and crazy, and even the best manager can't really control that given the circumstances that's going on during that time. A couple things is child and family care. Those were big reasons. The hospital just provided better hours to work weekends only, to let them off Monday through Friday and do other things like that. We did have one resident that went back to nurse practitioner school, and that's a full-time role, so she left for that. And the last one, the one that the only person that's left from the second cohort, she actually wanted more challenges. She really liked working in infusion, but she saw the same things over and over again. In that particular clinic, the clinic started slowing down a lot more, and especially in the realm of COVID. And so she took I believe, either a bone marrow and ER job at a hospital just to get more experiences, which is understandable, but unfortunate. Another question came in about OCN study books. We can ask pharma for that. A lot of the OCN materials are moving to virtual or digital. So really leaning on those ONS classes are going to be more important. But remember that we have the professional development funds. If you have people that need those or want those classes, then have them utilize those funds to get those different courses. What you can also do is maybe get a set of books for your site. So, if you have a bigger site, you might want to look at getting 4 or 5 OCN review books along with the testing guide. Smaller sites might just need one, and just check them out as you get going. But again, get with your practice administrator director to make sure they're on board with that, and then that's a way we can do it. But again, pharma is probably one of the best ways to get free books, so maybe look at leaning on them to get some of that for us. There was a question about the phase 2 courses, and if someone didn't pass the OCN, are those the courses they want to take? So just to review what those are: the treatment and symptom management, quality of life issues, professional practice, and prevention. So when we looked at the nurses just throughout the whole network, all of US Oncology, that didn't pass their OCN test, every single one of those people did not take that 4-class bundle beforehand, and those 4 classes combined is the OCN review bundle. So if you have somebody that is taking that test and utilizing one of our free take vouchers, then we highly, highly recommend that they also take that 4-class bundle set, because that just sets them up for success for taking their OCN exam, because those free take vouchers are free for the employees, but not free for us as an organization. We still pay for those. So if someone doesn't pass, I mean, it's very unfortunate. It has to be heart-wrenching for that nurse, but from a financial standpoint, it still hits our bottom line, and we have to then use another voucher code to get another one. So strongly, strongly recommend that everyone takes those, that OCN review bundle, so that way when they do take their OCN test, they're set up for as much success for passing as possible. Sorry, I'm reading questions. That's why I'm looking up. Yeah, so we did send out that survey, and the survey was geared at nurses that have been with us a year or under. So yes, some of that was during COVID, but some of that was obviously not. It was pre-COVID, and there was very clear themes that emerged, and a lot of it wasn't dedicated time, dedicated space, and IT training. So Centricity, Inamed, and all the other computer systems that we have was very pervasive in showing up of something that they wish that they had more time, more exposure, or even just a better physical environment to learn in. And again, I know that's very hard for some of your clinics. They're jam-packed, and you don't have that dedicated space or time to give to somebody. But realize that does affect their retention overall. And, Rhonda, Gina, and I really are looking at ways that we can help you all do better with getting those resources that you need, because we know that you're doing the best that you can. And us as the senior leadership, we need to do better about making other things available to you. There was a question that came in about getting permission for your PA and PDs about getting ONS classes. I would just remind your PA and PDs about the professional development policy and talk to them about the need for getting that in for your nurses, especially for some of those nurses that you think are struggling or definitely can benefit from it. Definitely want them getting what they need to, one, operate safely, but operating at the top of their licensure. And if you do have an issue with that or getting those approved, reach out to Rhonda and I, and we'll work with you and your PA and PDs to kind of come to a solution, so that way you can get what you need for your staff. I know we have a few minutes left. I did want to talk about one thing that wasn't on Rhonda's agenda, and that was the new nursing job descriptions that came out. I know that kind of came out fast and furious for everyone, us included. And and I know I spoke to a couple of people about this already, but just to kind of explain why that came about. Before they did this, we had about 68, 69 different nursing job descriptions throughout the network. And what that whole project was paring that down to roughly 18 to 20. One of the things that did go away was the OCN designation on the job descriptions. Now, you can still name somebody as OCN on their business title, but their job description just says RN1, RN2, RN senior, or telephone triage senior on those different things. So hopefully everybody has already talked to their staff about what that looks like. But again, just emphasizing that nothing changes with their compensation. It's just making sure that we're streamlining how we're designating everybody in the system. But in addition to that, and this hasn't widely been shared, there is a new clinical ladder development program that came with that. And as far as Texas Oncology, what we're going to do is I'm going to present that to the NEC, and we're going to talk about that and then make sure that kind of aligns with our practice. And then we will roll that out to you all the other nurse leaders. But that probably won't be until 2021, because we know everyone has a lot on their plates right now. But just know that really anything with this new job description, it's actually a good thing, but I know that it was a lot, and especially for all that work we did about a year and a half ago to make sure that everyone was designated as OCN, to see that go away was a little bit disheartening, and I totally understand that sentiment. The biggest thing with that is just ensuring that that everybody who has their OCN certification, that you have that in Workday and have that very clearly in there with the start date and the expiration date, because hopefully one day what we can do, as long as all of that is captured in Workday, that $1,000 bonus that we give out in the spring, that will automatically, the report will be generated from that, and then we can just push it out to accounting from there. Reading one more question. Okay, so this is talking about centricity and getting people trained. The revenue cycle team actually has a new trainer and a training program, and Rhonda was on the phone with them this morning actually talking about how we can partner with them. And there is hopefully very exciting things to come about that, so that way they can help us with that training and getting those different tools available to the sites. So again, it's another thing that we can take off your plate. As long as you can provide them space or an environment where they can learn kind of away from the clinic, that's probably going to be the biggest thing. All right, so yeah, and the very last thing I see on here is just talking about G2 and the trainers. I think that as much of a not, I don't want to say hassle, but anytime we have a huge implementation, there is a burden on there. But the good part about that is everybody's learning at the same time, the same materials. So it makes everyone go back into a learning mode again. And I think the onboarding for these new nurses with G2 after we implement, at least for the first couple years, is going to go very well because that's going to be very fresh in everyone's mind. But at the same time, there's a lot of courses on the Learning Center, on Centricity, or not on Centricity, sorry, on SharePoint that you can utilize for your training. Okay, so I think that finishes up this session. So what we're going to do is we're going to give you a small break, and then we're going to go into the peer review and in-prep training, and that will start at 2:30. So if you'll just go back out of the agenda, take a quick break, get up, stretch, and then we will move on to the next thing. Thanks, everybody. All right, welcome back, everybody. I know it was a quick turnaround, but we are going to jump right into peer review and in-prep training with Rhonda.
Thank you, Lance. Welcome back, you guys. We'll jump right in and get started. So I wanted to talk to you guys a little bit about nursing peer review and also the in-prep program that we have implemented at Texas Oncology as well. So we do have our peer review committee. And so for those of you who are online and are on the peer review committee, you're going to be very familiar with this. So bear with me. For those of you who aren't, we're going to just spend a few minutes talking about what is peer review, some updates from peer review from me, and then what is the in-prep and how it's going to affect you guys as nurse leaders. So what is the purpose of the in-prep? I'll call it. It stands for Nursing Peer Review Evaluation of Practice Breakdown. So in 2012, the Board of Nursing implemented a pilot program that used a modified version of the TURCAP. This is a program. The TURCAP ended their program in 2016, but the board worked to utilize the important findings of their pilot, and they created this implementation. It's a resource for practices to use. It's not mandatory, but Holly, Lance, and I looked through the program, and we find that it's beneficial. It's a good aid and resource for peer review committees, so we are implementing and using this as part of our peer review analysis. So again, the purpose of the in-prep, it's an optional resource that's provided by the Board of Nursing to support peer review committees for reported incidents. And the thing I want you guys to know is how will this change your role as supervisors or managers? Again, if you're on the peer review committee, you've already taken care of this and you've done this training. For those of you who are not on the peer review committee, we do want to ask all of our leaders to look at the training. It shouldn't take more than a couple of hours. More to come on that. We'll actually get something developed through the Learning Center, and you guys will get notified when that's ready. But we will ask all the nurse leaders to complete and acknowledge that you have gone through the Learning Center and completed the training. If you want to do it ahead of time before we get this out and reported to you guys, you can access it on the Texas Board of Nursing's website. You guys will all have access to these presentations, and I did provide the 2 links for the guide and the training. They're there on the bottom of this slide. Again, you can get them through the in-prep. If you just Google in-prep on the Board of Nursing the Board of Nurses website, you can find them there. Just a little bit of the high-level details of the in-prep process. So when an incident is reported to the Director of Nursing, then the director has to decide if there needs to be a peer review, depending on what actions may or may not have occurred. So when the peer review committee commences, we will use this aid, and there are several different rules and guidelines that they will give us. And just on your screen here are the high-level process of the in-prep and what aid us in making some of these decisions. So Rule 217.11, that is the standard of practice guidance. So that's provided in the form of questions. When you look at the orientation, you'll see that. This list is provided for the peer review committee member to help to identify practice standards not met. We may not always think of all of the practice standards. They may not always come to mind to us because this fortunately isn't something that happens often, but this is a guide for those nurses who serve on that peer review committee to look at to help them make decisions on if a practice guideline may have not occurred. Rule 217.12 is unprofessional conduct. This is the section that guides the committee to identify unprofessional conduct. Things like, if there was just ill intent from a nurse, or if there were any type of substance abuse involved, things like that. Those are some things that guide us through in that section geared towards unprofessional conduct. There's a section that's called nurse characteristics. And in this section, it asks about the experience of the nurse, what length and time they've worked in the clinic or the unit, what kind of hours were they working, what their employment status is, and how many patients they had at the time of incident. That's not all the questions that are on there. Those are some of the high-level questions. Again, these are all part of this orientation toolkit that we will go through as part of the peer review committee. It also evaluates system factors. It looks and it asks questions around the leadership and the management factors that could have influenced a practice breakdown. It also asked questions to see if the communication systems were factors in the breakdown. Environmental factors, other support factors, staffing issues. Were there other health team members involved in the breakdown, and other factors involving the healthcare team in general? So a little bit about determination of reporting to the board. As I talk to you guys about this, peer review sounds scary, and I understand that, but just do understand that any incidences that occur in your clinics, if you're not sure, if you think it might have been a violation of the Nurse Practice Act or there could have been something involved, please don't hesitate to report it to the Director of Nursing, which is Lance. Not all things you will report to us will be peer review. There are some incidences of things where remediation can be done, just simple guidance and re-education. But as a practice, this is our liability to make sure we have peer review committee and that we process it equally and fairly to everybody. So any event that you might have in question, please don't hesitate to let him know about that. And for this section for the peer review committee for determination of reporting to the board, this section aids in the various characteristics and factors that played a role in the event. These questions help guide the committee to help them to determine if reporting is necessary or if remediation will correct the deficiencies. If we do decide that remediation will correct the deficiencies, it also gives some guidance on classes you can, or courses, things that you can assign to the nurse for remediation and completion if you choose not to report to the board. It also gives guidance on when to report other system factors and breakdowns to the Director of Nursing. And again, those are what you might hear called root cause analysis. And any peer review that we've had, we've done some type of root cause analysis just to ensure everything is in order. Identified opportunities for improvement, and we'll give those practice and help to guide them and give them resources to help improve on whatever the breakdown might have happened. And then again, it does provide guidance. If there is remediation needed and not a report to the board, it gives you some clarification on what to assign and then ensuring follow-up is done and documented in that employee file. Just to review with you guys some common reports that we've had to the peer review. I just want to talk to you all, and Lance has talked a lot about this, but I can't emphasize enough the importance of to remind your staff in infusion that they're doing their chairside checks. That second nurse check is imperative. We have had an instance where a second nurse that checked or didn't check a medication has come to question just as much as the nurse giving a medication. So it's important and it's impactful that those second nurses who are checking things are checking them chairside. If they're saying that chairside, make sure it's chairside. Ask questions if something doesn't look right. If you are an infusion nurse by trade or a clinic nurse by trade, and that's what you do more than the other, you understand when something doesn't feel right, doesn't look right. Take that time to stop and ask that question, and make sure you understand how equipment works. That you've had proper training. If you're asked to use a piece of equipment or do something that you do not feel like you've had the training or you don't feel comfortable with, we all have nursing licensures, and it's our responsibility to say, I don't understand that. Let me learn more about that. And as leaders, we need to work with our staff to make sure to let them know they're empowered to tell you, hey, we've got this new whatnot. I don't know what's going on with it. I don't understand it, or a new drug. We need to learn more about that. Make sure to empower your staff and understand. If it doesn't look right, ask the question. If you don't know how to work it, don't use it. Ask the questions. Make sure you know how. And then also understanding that nursing licensure and performance are separate issues. So this is why it's important to make sure that the director of nursing knows if you guys have any questions about an event that can occur, that has occurred. The performance issues and the licensure issues, they usually go hand in hand, and we work closely together with our HR team, but those are separate issues. So just keep that in mind as you're working through any incidences that you might have in your practices. It's a pretty quick and down and dirty. There's not a whole lot else to tell you guys. On peer review, there is more to come. We'll get you guys those orientations. Again, you're welcome to look at the Texas Board. You just look up InPrep. The two links are there, and we'll send those out at a later date. and have you complete. I think Lance wanted to add just a little bit to this, so I appreciate you guys' time. I hope everyone's doing well. I miss seeing your faces. For those of you I haven't ever met, hello, and hope to see everybody soon.
Sorry. I'm the king of talking on mute, including this time. So, yeah, just to piggyback off what Rhonda is saying, is that anytime that you have an incident where patient harm has resulted, whether it's temporary, permanent, or worse, we have to know about it. We have to make sure that we're looking into it and we're handling it appropriately. Like Rhonda said, there have been occasions where when the nurse, even when it's not the nurse that was directly involved, but was part of the incident, has now been called to peer review before. So that is a little worrisome for us as nurses, realizing that the board is all encompassing. So we're, for a nurse, whether you're a staff nurse or even a nurse manager or a nurse director like myself, if the board thinks that we haven't done everything above board, then we are still nurses and they still have oversight over us, and we could be called before them. So that plays into onboarding still. So, the checklists that we have everyone do whenever you have a new hire, that's important. That can potentially come back and save or hurt you later. And ensuring that you're not just going through the motions of those checklists whenever you are completing them, that you truly make sure that your new hire or even your annual competency, that person is competent in that task before you're attesting to it. Because again, that form is saying, I believe that this particular nurse is competent to do this job. And if they make a mistake, then the board is going to look at, were they truly competent to do that job? And if they were, then the onus falls on that nurse. However, if they decide that that person wasn't competent, but they were attested to being competent, then that's when they can also take in to consideration, now, does that preceptor need to be evaluated or looked at? Does that nurse leader need to be evaluated and looked at? And that's not something I want for any of us. First and foremost, I don't want to go to peer review for anything. I don't want to go to the board for anything. I want everything to be perfect all the time. But unfortunately, we're human. Nurses make mistakes, and that's just unfortunately part of life. But what makes us nurses is that we take accountability for our actions. So again, just making sure that we as senior leadership, Rhonda and myself, know about these incidences, making sure that you have solid processes for onboarding and dealing with any kind of performance or clinical performance issues with your staff, and documenting those well. And so that way, if there's ever issues later on, you have a strong paper trail of what you've done with that person. And if there is any remediation, that you have that documented as well. All right. Well, I think we're done with that part, and I know it's not necessarily the best topic to talk about. Doesn't look like there were any questions other than not being able to hear me, because I'm a rock star with not being able to unmute. So we're going to give everybody a little bit more of a break this time to get up and stretch, do whatever you need to do. Make sure that you round with the sponsors, as always, and we will see everyone back here at, looks like 3:15. All right. Thank you. All right, welcome back, everybody. So the final door prize winners for this conference are going to keep on saying the wrong ones. So Trudy Webb is the $75 Starbucks gift card winner, and Heather Jordan, who is a social worker at Wichita Falls, is a JBL speaker winner. So congratulations, everybody, for that. Still remember that we have the grand prize and passport to prizes, so keep on rounding with the sponsors, getting those points up, and more chances to win. So next up, we are going to have Gina Foskey introduce herself and talk about her role as the infection control specialist and the new nurse educator. Gina, it's all yours.
Okay. Hello, everyone. I know a lot of you from working in my nurse manager role, but for those of you who are new, I'll give you a little background information about myself. I've been an oncology nurse for 23 years, and I've been with Texas Oncology 14 of those years, all at our Amarillo site. I was a clinic nurse for 9 years, worked as a nurse manager for 5 years. And as of August, I'm in this new role, which, as you can see, is actually 2 roles. Right now, my main focus every day, since we are in the midst of a little fun pandemic, is in my role of infection control specialist. I support the COVID task force by handling all the emails that are received, and then I provide guidance for those sites who are having COVID issues. In addition to that, I've worked on revising the COVID travel guidelines whenever the CDC changed their stance back in August. And I also created the COVID versus flu information for staff and patients, since we knew that this flu season was going to be a challenge, trying to distinguish symptoms if they were related to flu or COVID. And right now I'm working with some task force members to look over the coronavirus materials we have on SharePoint to see if any need to be updated, since most of these were created back in March when all this started. So we're working through those right now, hope to have those done in the next couple of weeks. In my nurse educator role, I am currently working with Rhonda, updating the onboarding materials, which she spoke about earlier. We hope to have all of these completed by the end of the year. We're also in the process of updating our policy and guidelines. We've had those 2 virtual in-services, the one we had on Eligard and the one on health literacy, which I hope you all found helpful. I'd like to have more in the future, but I don't want to overburden you with too many, because I know all of you have a lot on your plate right now. So I'm really wanting to limit them to important items that I think would be meaningful to you and that everyone needs to know. I do speak with pharma reps quite frequently, and since we can't have on-site visits right now, what I've been wanting to do is send out a monthly email listing all the reps that I met with the month before. And in that email, include their names, of course, the drug company they work for, and any new drug information or new indications they have for their drugs. And then I would share that with you monthly, and then you can look through those and see, which information is important to you that you want to look through and disregard the rest that you don't need. And I'm going to have those posted on SharePoint so that you can always go back and reference those if you need to look at something in the future. I'm working with Mandy Hodge right now on that, so we're hoping to have that up in the next 2 to 3 weeks, so more to come on that. I've made a few site visits that were needed, and hopefully I'll get to visit some more sites in the future once we can start traveling again, because I would love to meet all of you that I have never met before. I'm ready to have some human contact. So future plans for me. So both of these roles being brand new to Texas Oncology, they're a work in progress. Lynch, Rhonda, and I have some good ideas. It's just going to take some time to build them up since we are starting, from the ground. So we'll just work on it from the ground up. And if you have any suggestions or things that you would like to see in the nurse educator role or the infection control specialist role, just let me know. And if you ever have any questions about anything else, please reach out to me. And that's all I have. Back to you, Lance.
All right, thanks so much, Gina. So yeah, just to kind of to recap some of the things that we really want to start working on the nurse educator role is that we know that the burden of onboarding your staff and making sure that they remain competent with all their different things is can be just overwhelming sometimes. So really, now that we have Gina in this role, and hopefully when COVID kind of slows its role with ramping back up, we can get back to those things that we really wanted to do with a nurse educator and get more standardization going on. Like Gina said, we've had a couple of different programs going on, and we want to be able to hold more of those. But it's finding a good balance between getting the information out that you all want and need, but at the same time, not overburdening you and your staff with the different things. So there's going to be some learning opportunities for us and finding a good medium between getting all that out for you all. And it won't be a quick process, unfortunately. It's not like November is going to roll around or December is going to roll around and we're going to have absolutely everything you need. But we're hoping within the next 18 months or so that we can build this program up to such that you notice a change in the different challenges you're facing with getting your staff onboarded, on top of just the normal day-to-day things that happen with making sure that your staff operate in a safe and competent manner. In addition to that, once travel restrictions kind of lessen more, we definitely want to get back out to the sites more. We want to get in front of you all again. And part of that will be with Gina. Rhonda with the nurse leaders, Gina more on the staff level side, so that way she can help look at what's going on, give you recommendations and kind of tips on how we can get up and better your particular site. And again, remember that these are all recommendations. You take what we give to you and then see how you can incorporate it in your current practice. Now, if there's just something blaringly wrong that you have to change immediately, then obviously we're going to have to do that. But the other things, if they're truly just recommendations or best practices, then try to find a way to incorporate that into your clinic and site. So Gina, thanks so much for being part of this team, and honestly, just for being a rock star the past couple of weeks with all the COVID questions that have come in. I will say from our end, at the task force end, that the amount of emails that we've gotten the past 3 weeks definitely feels very much like it did in June and July. So, kind of reminding everybody that they need to remain safe, remain vigilant with all of our guidelines, our PPE guidelines, social distancing, so on and so forth. So again, thank you so much, Gina. You've done an amazing job.
Thank you.
Alrighty, so this was kind of a quick segment. So if everyone could get out of this one and then go into the dietitian one next, and we are going to introduce Karen Smith. Thank you. All right, welcome back, everybody. Now we're going to introduce Karen Smith, and Karen is our new Manager of Dietary and Nutritional Services, and we're very excited to have her join the team, and I will hand it off to you, Karen. Thanks.
Great. Hi, thank you so much. As Lance mentioned, my name is Karen Smith, and I am the new Manager of Dietary and Nutrition Services at Texas Oncology. This is a new role for me and the organization, and I'm just really happy to be here with you at this conference. In the time that we have together this afternoon, I wanted to review the services that we currently offer to our patients, and I'm looking forward to sharing a vision of where this program can grow. And of course, if anyone in the audience and on virtual conference land has any suggestions and tips, I'm very happy to take suggestions from this group. So the first and foremost thing I really want to say is thank you. I know it's been said before by other speakers, but it really can't be expressed enough. Thank you especially to Lance Ortega and Rhonda Boren and Stephanie Broussard for working so diligently to put together this conference and for inviting me to speak. And many thanks to others on the Operational Excellence team, including Holly Books, Dr. Wolfong, Sarah Toth, Melanie Nichols, Terry Jensen, and Carol Preet, who welcomed me so graciously into Texas Oncology and helped me get set up with all the different systems. And many thanks to the incredible nurse leaders here who have graciously and generously welcomed me into their clinics into a pandemic and provided adequate PPE so that I feel very covered. Thank you especially to Mary West, Mary Ann Cagle, Margaret Rhodes, and Janet Mullins. And I really look forward to meeting more of you in this coming year. And thank you for all that you do really to take care of our staff and patients every day. I am a big believer in mission-driven organizations. I think knowing why you show up for work affects how you show up for work. And I'm very proud to align the nutrition services goals with the overall mission for Texas Oncology to provide excellent evidence-based care to each patient we serve while advancing cancer care for tomorrow. So what does this mission look like in practice for a nutrition services program? So maybe this is as good a time as any to back up and let you know a little bit more about me. I grew up in Austin, which is where my parents still live, and I've been in practice for about 20 years, including about 15 years exclusively in oncology. And over the course of my career, I found that there are 3 integrated areas that make up most of oncology nutrition offerings at many settings. There's probably other ways to group and define these, but I feel like these definitions cover the area pretty well. We have service delivery, educational resources, and program development. The rest of my talk today will review and highlight some of the work that's already being done at Texas Oncology in these areas and where I'm hoping that this program will grow over the next few years. So let's start with service delivery. We do have excellent dietitians here at Texas Oncology. Nicole Hodak and Ashley Lenander at Salmons and Carla Heisel is at Dallas Presbyterian. And we have a strong partnership with Cancer Care Services to provide services to 8 clinics in the Fort Worth and Mid-Cities area. Obviously, this is just a fraction of the clinics at Texas Oncology, so part of my job will be to create plans to provide nutrition services to the rest of the organization. Stephanie Broussard's excellent presentation yesterday on social work reminded me that dietitians also have their own unique alphabet, of which the most foundational letters are the RD or RDN. This is, people often ask me if I'm a dietitian or nutritionist, and the truth is that I am both, as are the other dietitians at Texas Oncology. All dietitians can use the term nutritionists, but not all nutritionists are dietitians. Being a dietitian means that you have a bachelor's degree, have completed an internship, and taken a licensing exam. And if you've been practicing for more than 5 years, you have 75 continuing education hours every 5 years to maintain your license. We're also really lucky at Texas Oncology that all the dietitians have advanced certification. Most of us have advanced certification in oncology, which means that we have over 2,000 hours of specialty oncology practice. And the LD is the Texas license. So the CSO also is something that you have to maintain every 5 years. So what does this license actually qualify us to do? This is just a quick note about what the legal definition of nutrition services are. We are qualified to provide medical nutrition therapy, which is diagnostic therapy furnished by a registered dietitian or nutrition professional. And it is a specific application of a nutrition care process that's focused on disease management. The nutrition care process is a complete cycle that involves screening, referral to a dietitian, assessment, and follow-up care. So that brings me to the first part of the process, which is screening. I know we've heard a lot about screening today from in this whole conference about the importance of screening, and just in other areas, nutrition screening is very important as well. It helps us focus where to direct scarce dietitian resources. At Texas Oncology, a lot of clinics are using the malnutrition screening tool, which is here on the slide. And this can be filled out by hand and scanned into the chart. The other side of this slide shows that organizations like the Oncology Nursing Society advocate for nurses to identify malnutrition because we know it affects treatment tolerance and quality of life. So it's important to look at in practice. Once patients are screened for malnutrition, whether it's by the MST or another method, ideally they get a referral to dietitians. And what that looks like in our practice, especially at Texas Oncology, where there are just a handful of dietitians, is that the dietitians do focus on very high acuity patients. Usually patients on enteral nutrition, which means feeding through a tube, or parenteral nutrition, which means feeding through an IV. They also focus on patients who are malnourished or who are at very high risk for malnutrition. We know that head and neck cancer patients fall into this category and that they benefit from being seen frequently by a dietitian during the active part of their treatment and sometimes for a long time afterwards. Patients with cancer elsewhere in the GI tract also fall into this category. And depending on other factors, patients with other types of cancer or cancer elsewhere in the body can be at high risk for malnutrition, which is another area where screening becomes necessary. And thank goodness, the patients with head and neck cancer, GI cancers, or who are at risk for malnutrition do constitute a relatively small portion of the patients, but we also know that all patients with cancer benefit from some type of nutrition resources. So this leads me into the program development piece of our program. Since not every patient will be able to be seen by a dietitian, part of my goal is to create nutrition programs that will help us reach other patients. Texas Oncology has great programs already in place, and it's been very inspiring to speak with people like Gail Patel with the genetics program, and of course Stephanie with social work, to find out more about how they've grown their respective programs. Certainly nutrition services and pharmacy have a lot of great work that we can do together to serve our patients. And the foundation work, this is one of the pictures on the slide is Nicole Hodak giving a symposium talk for one of our foundations. And Carla Heisel has been recognized for her work with dietetic interns and her extensive work with the patients in her clinic. So part of the things that I've done in the last 90 days is also identify some opportunities that we can do. Some of these are quick wins, and some of these will need a little bit more work to flesh these out. One of the things Melanie Nichols has so helpfully helped me with is to send out a survey to the practice administrators and directors to assess clinic needs and opportunities. I've worked with pharmacy on reviewing the products that they offer in the retail pharmacy and developing some guidance with regards to new products that we can offer our patients. Mandy Hodge has done a lot to help support me in getting materials up on SharePoint, which should be hopefully done certainly by the end of this year, hopefully by the end of the month before Thanksgiving. And then as soon as we can get all the materials together, and then developing policies and procedures to support the teams in clinics. Because there are such great programs here with survivorship and genetics, I do hope to leverage some of the work that's been done with those groups to offer programs, especially in healthy eating, to more of our patients. And these are some of the examples of evidence-based, well-researched organizations who already provide good resources with nutrition in relation to nutrition and cancer. Sarah Toth already uses materials from the AICR, which is the American Institute for Cancer Research, in her patient binder. Certainly the American Cancer Society offers a lot of good nutrition advice and materials. And then there's some more disease specific, like Oli.org is a head and neck cancer or enteral nutrition organization. And then Lance is has been great in helping me get the nutrition care manual, which is a extensive nutrition resource with many type of education materials and menus that we can offer to our patients. There's certainly ways that we can connect dietitian resources both in Texas Oncology and in communities where there's not a dietitian on staff. And through the foundation, Nicole Hodak has developed a pretty extensive collection of webinars that I hope to be able to offer easily to the clinics as well. So with service delivery, program development, and educational resources being the foundation and influencing each other in the program, all of these sections are here. I do hope to grow them all and be able to offer them more extensively to the clinics. And with that, I just want to come back and say thank you again. Thank you to the nurse leadership team and the social work team for having me come speak. And I'm certainly happy if there are any questions. I think that I talked really fast, so I'm happy to answer any questions if anything came through.
All right, thanks so much, Karen. And we are very excited to have you join our team and bring your expertise to Texas Oncology. So like Karen said in the beginning of her talk, most people didn't know, myself included for a while, that we already had dietitians within the practice. All of them are in the Dallas area with the exception of Karen now. So 2 at the Sammons Cancer Center and 1 at Dallas Presby. And what we're hoping to do with Karen is, one, like she said, expand this program so that we give the sites the materials they need to help with patients, but then also, like the social workers, potentially expand the number of dietitians we have available so that way they can see our patients and help with those things that really need the expertise of a dietitian and a nutritionalist, especially in the realm of oncology and head and necks and those different things that those people typically have poor outcomes to and have great nutritional needs. So Karen, thank you so much for all that you've done in the very short time that you've been here. Don't be surprised if Karen reaches out and potentially wants to shadow your clinic one day. Please welcome her with open arms because she's going to bring a lot of great materials with her one day. And yeah, it doesn't look like there's any questions. So what we're doing is we're going to take about a 2 to 3 minute break, and then we are going to go into implementation tips for Generation 2 Inamed with Pedro Villa again. Okay, everybody, we are going to now talk about G2 again, because we know that's everybody's favorite subject. And originally in this segment, what we were going to do is we were going to have the San Antonio team talk about their kind of lessons learned and helpful tips for implementation. However, less than a week from today, their G1 access is going to switch to read only at noon, and then they are going to go live that Monday, the 26th, with G2. So they are so close to their implementation. That team decided to just kind of stay at home and make sure they had all their ducks in a row, which we completely understand. So I asked Pedro to come back and talk to us about his historical knowledge with implementing G2 and things that we all kind of need to be mindful of whenever our turn comes. So I am going to hand it over to Pedro. He's going to walk us through some things, and definitely want to open it up towards the end for Q&A to talk about all the different issues or questions you might have. And then after the end of this segment, we have just an open forum Q&A for our very last thing. And we can bleed into that if need be, or that can be completely separate. So Pedro, I will hand it off to you now.
Hey, Lance. Yeah, thanks again for having me back. Yeah, G2 is going to be probably one of the biggest, not the biggest project that Texas Oncology will take on. And as y'all know, this project won't even come to its full completion until the summer of 21. So there's a lot of space and opportunities in front of us. And I think the first thing I want everybody to be aware of, and hopefully this helps temper down some of that angst, is when we shut down your G1 during that migration period, we shut it down for a short period of time, and then it comes back up and it's only a shell. But what that means is that you could still go into G1 and you could still go look for things like progress notes or attachments, any kind of documents that were attached into the chart. You can even print out schedule orders and things like that from G1. The only thing you can't do in G1 obviously will be documentation. So I like to mention that in the beginning, because a lot of times that comfort of knowing that you can still go back to G1 and go look for an order for that patient that's sitting in their chair really tends to calm the nerve a little bit. In this way, you want to be able to just move forward and treat your patient, right? And then work with the G2 team and the support resources there to help you with next steps. But making sure that we keep our focus on treating our patients as efficiently and as carefully as we can. And so I always like to start off by mentioning that we still will have access to G1. You still will be able to print from that. So just be mindful of that. But when we do start talking about preparation for G2, I think one of the biggest challenges that we come across, and especially now because of the pandemic, where we're forced to do a lot of things remotely, is finding a dedicated space for your training. It's not like if we were on site and we can be in the room and hands-on with you guys and making sure that you guys are following along, or you guys are plugged in and head down on your laptop and working with the team during your training sessions. So it's a little bit challenging when it's virtual, right? We have, however, implemented a new software called Land School. Some of you early adopters that are transitioning over to G2 may have not had that experience with Land School, but for the rest of the folks that will be converting to G2, Land School is an application where it's basically like a virtual classroom. So you'll have one instructor, and let's say there's about 6 attendees in that class. Well, that instructor will be able to look at 6 screens. So this instructor will be able to see if everybody's following along. If somebody's falling behind, then we can definitely stop, address it, or maybe reach out to that person to see if there is something else that they don't understand. So we are acquiring these technologies to help with that training. But in the meantime, for those that do not, we really can't know where exactly your teams are if they're not in an area where their time and dedication and attention is solely on that training. Not only that, but it's also highly important if there's dedicated space. A lot of times in a lot of practices, they don't have that kind of space for that training session. So either they're going to take their training session in a lunchroom, or they may be interrupted with staff coming in and out for, coffee breaks or for their lunch and whatnot. Or oftentimes they're going to have to take their training session at the desk. And of course, we know that if somebody sees you, whether it's a patient, it's another staff member, or it's your providers, if they see you, they don't know what you're doing. So they're going to come to you and they're going to ask you for things like, hey, could you put an order in for this? Hey, can you call a patient on this? Hey, can you do something? And that really takes, that attention away from the classroom and your training session. And those interruptions and distractions can really hurt you guys down the road in trying to become that subject matter expert, in trying to become that efficient trainer to go back and train your team, or even as the end user themselves to really understand the application and how to be successful right out the chute if you're constantly being interrupted or being taken away from your training. So those are obvious things that, and I get it, sometimes it's just not possible. What we do is we truly do ask for you guys to really commit to this. We even send this message up to your practice leaders. It's a message that I will convey during the kickoff to your physicians and your physician champions, and including your executive directors, that we need their support. The subject matter experts and trainers will have to step off the floor for about an hour a week to attend project calls. And it's important for them to attend those calls because a lot of updates are provided through those calls. And so this way they know what to anticipate. Is there a new enhancement that's coming into the application that they need to be aware of? And that's an opportunity for us to demo that enhancement. Things that maybe they have some news that they need to share with us so that we're aware of. If there's certain people that are missing training sessions, maybe there's a construction going on in El Paso that staff are having to travel somewhere, so timing might be a little bit off. So we tell them, those leaders of the practices, to support us and support them, more importantly, to allow them to attend their training sessions so that they're engaged, and so that they're attentive, and so that they have all the material and they take all the training to help them be confident in the ability to not only support their own site, train their own staff, but ultimately be successful day one on generation 2. So again, making sure that you have dedicated time, dedicated space for those trainings and for those meetings, but also you guys will be provided with an electronic learning called the LMS, or the Learning Management System, that's assigned to you guys through your e-learning website. I can't stress enough how important it is for you guys to complete those sessions and complete them in a timely manner. We stage them out so that you will take one session and then you meet with your group, with the G2 expert, and you review the material that you just took, right? Because those modules are not very interactive. So you take the module, it shows you where to go. You can click on a few things to kind of understand where to click to enter a vital sign, for example. And then there's a short quiz at the end as more of a knowledge check. Making sure that first, obviously, you paid attention, but you understand what's asked in those quizzes and to know exactly where to go. But then we just layer that on with those weekly SME calls, with those training sessions. So an opportunity, again, for those people to ask the questions that they weren't able to through those modules. And so it's highly important that the staff completes those training sessions in a timely manner so that they're able to attend their sessions and have very, very effective conversations with their G2 trainers to be able to ask the appropriate questions and to help them understand the module and what exactly is going on within those sessions. So it is important that you guys encourage one another and all folks to complete their LMS training once it's been assigned to them. It's a great tool. It paves the way to really getting introduced to G2. We know that it's not going to be the end-all say-all for your training sessions. But what we have seen, and this is specifically speaks volumes to our physicians, when somebody takes those LMS courses, and even again, it's just an introduction, it just builds a foundation into G2, oftentimes we realize that the training sessions that we have are more meaningful because now we're not just talking about this is where you click a vital sign. This is what your patient banner looks like. They actually have already retained that from their session, and now they're asking more about, can I enter a vital sign in my patient banner? The answer is yes. Can I go ahead and do XYZ? And so that's why we really encourage that your staff, once they're assigned those LMS courses, to really take the time to complete them in order for them to build that first step into G2. We'll provide you guys with weekly summaries or progress reports, if you will, to kind of show you exactly where your staff is at as far as completing their assigned courses. So this way, your leaders, the practice leaders as well, can be aware of what's going on with their staff. Are they completing them? Are they not completing them? And if they're not completing them, is there something there that's impeding them or conflicting with the ability to go in and complete their LMS coursework? Is it just the fact that they just don't have the time in a day, which is completely acceptable? And is there something that the leaders can do to work with that individual to ensure that they complete their training sessions? So I repeat it all the time, right? We want to make sure that we have dedicated time to ensure that we're really engaged in the process in this rollout phase. And also we want that undivided attention. And we can't do that unless we have dedicated space. We want to try to minimize as much of the distraction as possible. Obviously, there's going to be scenarios where there is a critical matter or a situation where that person on the call will need to get pulled away from, and that we can't control. But if at all possible, if we can keep them aside to be able to be a full participant in the process, that it's only going to bode well for them and for the practice as well, because you'll have that person with that knowledge. And then, of course, those LMS courses that they're initially assigned to them, it's just a great way to help introduce them to G2. For many of them, it may be the first time they've ever seen G2. And so there's going to be a million questions that are going to come out of those modules. And so the way it's timed out, again, is you take your first session, you meet with the G2 expert. That's where we have meaningful conversations about what they just saw in their LMS courses. We have learned too, through the rollout phases, that there are a lot of roles that are different than what we're used to working with. A perfect example was the clinicians or the clinical staff in San Antonio with the nurses and the MAs, and also the difference between an MA and a certified or registered MA. So we always go in with the MA, it does X, Y, and Z. And come to find out that in Texas, there are differences in roles and responsibilities between a registered certified MA and your traditional MA. Well, we don't know that. And the one thing that was kind of a rude awakening for us was really being sure that we asked the right questions about how a clinic, what's the clinic makeup. But also we rely on you guys to really call us out or bring to our attention a lot of the roles that might be different, even those hybrid roles. Going back to my days at Salmons, if you go to a site like Greenville or Waxahachie, there's only a farm tech. There's no pharmacist. So what does that look like? What is that makeup? So for me, coming from Texas, I'm familiar with that. But the team that's working with the Texas Oncology Group are not. And so it would help us if you guys bring that to our attention that, hey, I noticed that you guys had Lance Ortega on for the MA, but Lance also does the front desk. He also does the check-in, check-out. And so in order for us to better understand what Lance will need to be prepared for G2, we need to know that, so that way we can assign those appropriate courses to Lance so that he gets everything that he needs. And then also to be involved in a participant of those virtual calls, right? Because we do break them down by role. But if Lance wears multiple hats, then we want to make sure that he's invited to all of those sessions so that he is able to perform the functions that are within his responsibility and his role in his clinic in all facets of G2. So it really takes, a back and forth relationship between us and Texas Oncology to better prepare you guys for what's to come. And if we don't know what the landscape looks like, then we could be missing out on a big, big group or creating holes or gaps in the training in the workflow, to where someone might have the training that they probably do 60% of the time, but then that 40% that's left, even though that's not their primary role, is still very significant to the practice. If this person doesn't know how to process an order on the queue, then that's a problem. They may be well versed in entering vital signs, current meds, things like that, but without us knowing that this person wears multiple hats, that's where that's where problem will lie, is not trying to identify or not being able to identify what that person does. So we really encourage you guys to start that dialogue with us. And we started very early. We just did it with NTER, where I have one of my coworkers reaching out to the practice and getting those people's usernames as well as their specific roles. So not just the fact that they're in nursing. What about in nursing? Are they an infusion nurse? Are they a clinic nurse? Do they just run shot clinic? Things like that. And so making sure we identify exactly what you do in that practice and what else do you do in your practice, to be sure that we provide you guys with all the material that you need. And then, of course, we always ask to bring your patients. Again, we're all, I guess you no longer want to call this our new normal, but we've all kind of had to work with some of the challenges now, virtual. And a lot of times we can't see what you're seeing, nor can, sometimes people are talking over each other on these calls because everybody has a lot to say. We just ask for your patience through these sessions, through your training sessions, and then ultimately leading up to your go live and to your support weeks. We are all in it together, and you're not successful if we're not successful. And so we want to make sure that we hear everybody's questions, comments, feedbacks, and concerns. Don't hesitate to reach out to me by email. I might not have the answer because that might be my implementation lead that's really taking point in that, but I can definitely either point you in the right direction, or I can get that answer to you and then bring that back to you guys and then see if, did that make sense, or do you need more explanation? And I'm happy to jump on the call. But we really do ask for your patience with this and really taking advantage of the opportunities that you have in front of your G2 experts, not just through your training sessions, but even on site. A lot of times people are hesitant to reach out to a G2 expert. They just don't know who they are, or whatever that situation may be. They're not comfortable reaching out and asking for help. That's why we're there. And frankly, that's why we pay them. So don't hesitate to reach out and ask the questions to our staff. Take full advantage of them. We're going to be there from the minute your doors open that Monday morning until the very last patient walks out, and maybe even longer, to make sure that you guys have completed your documentation. So we have nothing but time, and our full focus and attention during your go live weeks throughout your phases are completely on Texas. If I were to show you the team that's committed to this project, and during that time of go live, that their only responsibility is Texas, it's unbelievable how many people's eyes and attentions are on this. And as your account manager, I'm happy to see that attention being placed on Texas, because we have the eyes and ears of your developers. We have the eyes and ears of our leadership team, of our implementation team, project managers, and myself. So we take this very seriously, and we are fully vested in your success in the rollout of G2. So, if there's anything that you guys take away from this, is use us and abuse us. Take advantage of every opportunity that you have with the G2 expert. Ask every question you have. The only way we know whether you guys are struggling or you guys are getting it or not is if you're engaging us and you're, having these conversations with us. So Lance, I don't know if you wanted to open it up for questions, or you already had questions in the queue. Happy to take those questions for you, or if you had anything else to add.
I do. Thanks so much, Pedro. So yeah, there are a couple questions and then a couple things that I want you to hit on as well. So one of the first questions that we got was, the admin functions that nurse managers have access to current state in G1. Well, they have that in G2, and there's audit report and different reporting functions that we can make sure that's part of the nurse manager role. So to give you a little bit of a background of how this all started, is that we've been preparing for G2 for well over a year now. meaning that we did workflow analysis of current state in G1 and got all of that. We brought in subject matter experts from across the practice and made sure that we understood how everyone was practicing in the system in G1, and then basically use that document to translate into G2 to then build our workflows off of that. Now, all of that extensive work, I mean, being completely honest, there's probably going to be things that got missed or left out, or assumptions made about the functionality in G2 as opposed to G1 and how that is specific to Texas. The good thing about this tiered approach is when San Antonio goes live, we'll have lessons learned. I think overall it's going to go really well, but do I think everything's going to go off perfect, or do I think we didn't miss anything? No. But we're now at that stage. We don't know what we don't know until we experience it. And then when those things do happen, we're going to revamp our workflows. We're going to make sure that we incorporate those different things. And so that way, as the different waves do progress, we're going to take those lessons and best practices and put it into your implementation. But yes, you will have the ability to run audit reports, to run medication reports, that sort of thing. And then moving forward, our internal iNamed G2 team will handle those accesses for us and assign that out as needed and change things as needed. Pedro, another thing, and this was, I guess, more of a comment about the training session. So one of our nurse leaders had signed up for multiple sessions, so MA 1 and 2, APPs, RNs, pharmacy, so on and so forth. And it seemed like the very first session for almost all of those were similar, because it's a foundation. So I assume that's how most of it gets stair-stepped up. So she just said that it would be really helpful for the nurse leaders to know that part of it, so that way when they do sign up for session 1, and that pretty much covers them for all session 1s, and it's the session 2s that really break down into the specific job functions for that whatever role it is. Because whenever she did pull it up, she was hearing a lot of the same things over and over again. So maybe just a kind of a tip for later on for whenever other regions start going live with it.
Yeah, that's a good point. And we'll make sure that we bring that up. Obviously, we just want to make sure that they have plenty of opportunity to join. So I think if we explain that a little bit better, that the very first session is just it's the same material that's repeated. So just signing up for one is sufficient enough. Good point.
Yeah. One of the questions, or a couple of the questions, are about running reports. Now, reports in G2 are a little bit different from G1. Some of them in current state in G2, we might have to request them to be ran for us. And some we have the ability to run ourselves. And again, as we're looking through those different things, we might put in enhancement requests so that way we can change some of that functionality to be more user-friendly for us. But that's something that we'll incorporate into training, and we'll make sure that we flesh that out a little bit more. And it's kind of hard to show you without being in the system. But Pedro, definitely going to bring that back to you. And during our different subject matter expert sessions or leadership sessions, I'll make sure that gets built into our workflows so that we do that for the nurse leaders. So is scanning and detaching in G2 in any of the clinical sessions, the iNamed attachment guidelines being updated to reflect the different tab titles? So that is, scanning and attaching is covered, but I don't know if we put in a guide or a key to say how to specifically name anything or name everything, in there. And so that might be something that we work with Lexa and see what their nomenclature is, so that way that we can replicate that. But Pedro, are you aware of anything like that, current state in the workflows for G2?
Yeah, and that's a very good question, because as we bring all of your divisions, all of your regions onto one platform in G2, it's important that we create consistency, right? To be able to identify where does a report live, regardless of what region you work or live in or work in. So what we are doing is a couple of things, actually, to make sure that all, across the board, we're covered. Well, we're working with Carol out of Medical Records to get like an Excel spreadsheet of what the document name is and where exactly it's going to be, you're going to attach it to underneath those document filters. And working with Lexa Records as well and creating that uniformity So regardless of who's scanning and attaching that specific document, it's going to go in the appropriate tab. Regardless of where you are, if it's El Paso, Dallas, or Houston, it's going to be the same descriptors, and it's going to go under the same categories across the state of Texas. And I believe they're going to publish that out once they've come to a definitive decision on exactly what that naming convention and where those categories live. I believe we finalized the document tab names. So now it's a matter of making sure we cover all of those specific document types: PET CTs, MRIs, ultrasounds, outside labs. Where will all of those live in its appropriate category in G2? And once they've signed off on that, then I believe they're going to publish that out so people are all aware of where exactly you're attaching your specific reports.
Perfect. There was another question that came in about promoting interoperability, and is there going to be a promoting interoperability class about making sure we're clicking the right things to meet the measures? So in the workflows embedded into it, it does show how to reconcile, how to do inbounding and outbounding appropriately. In what we've built already. However, when our reporting period comes back around for next year, the same process that we've done for many years, where Paula presents all of the different measures and how to do it, that still will hold. That will still hold that session, and the screenshots and the job aids will be G2 specific as opposed to G1 specific. But all of those should be on there right now. And then Kathy brought up a really good point. So there is a G2 page in SharePoint with a ton of information in there. So be sure that everybody looks at that. And again, it's probably not going to answer everything, and there's a ton of information to work through, but really for those people that and really looking at NTR and WTR for those two servers, you really haven't had a lot of exposure to it. So if you want to go in and check those materials, they're there for you to kind of peruse and look through. Now, Pedro, something that I wanted to make sure that we hit on, can you talk about chart prep, and what does chart prep mean for G2 and implementation?
Yeah, so chart prep isn't what we would expect it to be if those of you who have been around since the paper to G1. Because we're migrating data from G1 to G2, we actually do pull forward quite a bit of information. Things like their problem lists, their vital signs, their current meds, allergies, including their regimens and the documents, the attached documents. So we pull a lot of that into G2 already from G1, so we don't have to spend a lot of time in the chart prep phase, if you will. There are still those things that are entered in G1 that are a free text form that don't really have a one-to-one match from G1 to G2. So those are some of the areas that will require a chart prep, manual chart prep, if you will. Things like an insurance alert is one of those things that does not migrate over. And so we're working with Texas, and we're actually working with Lexa Records, who are assisting us in helping with the chart prep phase. So the nice thing about it is we're taking a lot of that manual work away from the practice, where the practice is already being doubled up, right? They're there to treat their patients. They're being trained on G2. Some of them are SMEs and trainers, and they're being pulled away for meetings. So there's not a lot of free time left. Oh, and let's not forget your e-learning courses. So there's really not a lot of free time left for the sites and the staff to work on this chart prep. So we've engaged Lexa Records to really help with that process to fill the gap on what those chart prep items are needed still. Things like the chart alert. And I think the biggest thing in the chart prep process is the physician's progress notes. That's another major area that does not migrate because it's got a different build. It's got a different feature and an entire different aspect all put together from G2. And so what we're asking Lexa Records to do is to go into G1 and look for their most recent progress note. And they're basically cutting and pasting some of the pertinent information and categories that was agreed upon by Dr. Wilfong and his physician governance committee on what were the sections in that note that they felt needed to be there in order for them to transition from G1 to G2. things like their HPI, their Chief Complaint Assessment and Plan. And so Lexa Records is taking those identified sections and copying and pasting them into a transition note template of Generation 2. And so once we go live with G2, the functionality within those chart prep template or those chart progress note templates will start to take form, and they'll start to carry that information over based on that chart prep that Lexa Records did for us. So there's not a lot that needs to be done. However, some of the information that's not part of the migration is very significant information. And so we want to make sure that we identify what that information is and get that chart prepped into G2 before we go live with them. And it's important too to know that they are aware of what are the areas in the chart that they need to stay away from. So even though you may have access to G2, if I go put in a progress note, or if I go, not progress note, but if I go in and I put in a vital sign or an allergy and I'm not supposed to be doing it yet, there is a possibility of the migration for that specific field to break and not bring forward that information. And so that's why we wanted to make sure that the people that were going to be assisting us with this were trained and trained very well by the G2 team, but that they limit the access to how many people are in the G2 environment at that moment, so that way we don't create any kind of unnecessary just information that doesn't need to be there yet that can corrupt the migration process.
Perfect. Yeah, and then also with chart prep, chart prep will extend beyond implementation. So you have those patients that might be in every 3 month, every 6 month, every year follow up, and so Lexa might not hit those. So part of what the sites need to make sure that they are competent in after implementation is knowing how to do that chart prep. It's a really simple process, and what we'll most likely do is just do a quick WebEx. We'll record it and then post it to SharePoint. So that way that, if you haven't done it in a while, but you find that you have a couple patients coming in that we're past the implementation phase, we'll make sure that those materials are available to everybody. So that way you're not kind of in a lurch when you have new patients coming in or new patients to G2 coming into your practice again. A question that did come in is about procedures. So those procedures like CT scans, echo scans, will those automatically be dropped into G2? And I can answer this up to a point, but Pedro, keep me honest. There are document interfaces, the HL7 interfaces, that should be able to load those directly into the patient's chart and document or produce the document into the Documents tab as a PDF. But Pedro, I'll let you take it over from here and kind of clear up anything that I didn't touch on or got wrong.
No, yeah, you're absolutely right, Lance. So basically what we do from G1 to G2, if you already have an established interface in G1, all we do is we repoint that interface into Generation 2. So if you guys were receiving today CT scans via PDF, then we're going to still receive that into Generation 2. I think one of the things that makes it a little bit more simplified is we have what's called a document listener, which basically is listening to a dedicated folder either on your network or in your workstation. And any item that drops into that folder is going to be immediately consumed out of that folder and into your attachment queue. So we basically remove the middleman, if you will, where you have to go search for that file, and then you go click on that file, then you look for the item, then you double click it to bring it into the attachment queue, and then you start your work on attaching that document to the right date, right patient, right category. In G2, with our document listener, basically it's always listening, and anything that drops into that, so if it's an external fax that comes in, it's a CT scan report or result, it hits that folder, document listener will scoop it up, send it straight to the attachment queue, and then that staff there will just take that in and attach it into the appropriate charts.
Great. Thanks so much. All right. Any other questions about G2? You'll probably all, as this gets closer, there's definitely going to be more that pops up. trying to think of other things that I really want to make sure that you keep in mind for this. Oh, data cleanup. So that is an important thing. So many times there's duplicate patients in different databases. That happened a lot in San Antonio because San Antonio has two databases for that region. Looking at Dallas and Fort Worth, you're in NTR and WTR, and there's some patients that are shared between those. So whenever you migrate that data, remember we're coming from 7 different G1 databases into G2. And so there might be times, especially when you get closer to your implementation, that you're asked to DC regimens, make sure date of death details are kept up, those sort of things, because if there's conflicting information or incomplete information, kind of what Pedro was talking about before, that kind of it's a fallout, and someone has to manually look at that. So if we can prevent all the back end work and just do it on the front end before the migration happens, that would be very important in making sure that everything's efficient when data starts migrating over into G2.
Right. Yeah, that's a great point. I know that's Will Fong's platform, right? Is making sure that we get charts cleaned up before that migration. And I think that's a great takeaway is for those sites to go look at those regimens that have just been out there lingering, right? They're no longer active, but then nobody else did anything to that. And so what happens is that gets migrated over. And to Lance's point, then you just got a chart full of inactive charts or regimens, and there may be a time where all 3 or however many regimens will hit the same data service. Do we know exactly which one's the active versus inactive? So just like the physician queues, that's another thing that Will Fong is really pushing for, is cleaning up the G1 charts before the migration weekend.
So another question that came through is mock clinics. So Kathy, thank you so much for that. Yes, there is going to be mock clinics that will be ran for every site. And what that entails is that we basically do the path or the flow through the clinic of a patient. So we start at the front desk, check them into, if it's a new patient, check them into PBRs, check them into the clinic, then check them into lab, and then discharge them from the clinic. Then we do a scenario for a established patient, checking them into the lab, checking them into the provider, checking them into infusion. And then you go through the steps of all the charting or all the clicks that happen in G2 for that patient. We started doing time studies on those, and to room a new patient in G2, it takes anywhere from 12 to 18 minutes to do that. Now, there's roughly the same amount of clicks as there is in G1, but now that we're seeing the mock clinic and people are able to kind of get their hands around what it will look like when you do have a patient in the clinic, you also have to make sure whenever you do go live for implementation that your schedules are pared down, because we know that we can't see the same amount of patients with a brand new EHR, because we're going to slow down with everybody's familiarity with what they're doing, but also we have the physicians involved, and they are not going to be as quick at doing things as well. And so we know that there's going to be a lot of bottlenecks involved with go live for the first couple of weeks. So making sure that if you haven't already done that you're looking at your schedules and making sure they're pared down for the first couple of weeks at least, and then you can start stair-stepping them back up. There are test patients or fake patients in G2. So whenever we are doing a mock clinic, we're using those test patients. We try to assign everybody their own test patient so they can play around with it, edit information. We do have the ability to put pictures patient pictures into G2 and attach it to their chart. So whenever you pull up that patient's chart, you can see their picture in front of them, so you can play with what that looks like. But yeah, the mock clinic is going to be very valuable and very informative whenever your turn comes around to actually doing that.
Yeah, it's a great opportunity to apply that workflow, right? It might differ from what you guys are accustomed to seeing because of trying to create the standardization across Texas. So it's a nice opportunity for us to really test drive that workflow and see how that fits into our system and into our clinic well before the go live. So it allows us to pivot or modify wherever we can to make it work. But also what I like about it is that through leading up to that, you're in these sessions, and it's a session that's kind of circle around MA, circle around the RN, circle around pharmacy. But the mock clinic actually brings all of that together. And so then you can see the handoffs, right? I know that was one of the things too, Lance, that you guys were looking at is the clean handoffs through this mock clinic. What happens if somebody doesn't do their fair share in the application? How does that impact the next person? And if we make sure that we enter all of our information or we fulfill our responsibilities in G2, then it can continue through that visit very seamlessly. And so one of the things that was really something they wanted to focus on was clean handoffs. And you're able to see that in that mock clinic exercise to see what my role does, what do I do in my role, and how that could impact those behind me in that visit, ultimately leading that patient out to check out.
Awesome. So there was a question about login. So whenever your training starts, you're going to be assigned a login, and there's multiple G2 environments. So there is a training environment and there's a production environment, and Pedro hit on that a little bit. So training is where you learn to do everything. Production is where you could potentially mess something up. So we don't like you to be in that until later on in the process. But so if your region or your server has gone live, you should have been assigned a username and a login for that. And if you have and it doesn't work, or everyone else has it but you, then please reach out to the G2 team, and they will see what's going on with your access and get you into the system, because we definitely want you playing and training. We want you going through the different patients or the charts, clicking on the different areas and getting yourself familiarized with where to go for everything. There's a question about PTO blackouts. Yes, there does need to be PTO blackouts for implementation, but that is going to be in the immediate weeks leading up to implementation and the weeks after. There's virtual training that needs to happen along with the Learning Center courses, and then actual go live. Now, this is not going to be like Centricity where there's months of blackouts, but realistically, there's probably going to be anywhere from 4 to 6 weeks that we're going to have to black out from right before to right after your implementation, just to ensure that everyone gets the training that they need. And then we have everybody all hands on deck whenever you do go live with your implementation. All right. Any other questions that you all have about G2? Okay. Well, I mean, for those of you that haven't seen the system yet, other than what Pedro showed us yesterday, which was awesome, by the way, it really is an intuitive system. When we did our first mock clinic with San Antonio, we had a physician that had never played in the system before, and he was able to click through and find the different areas with relative ease. It was impressive. So it just goes to show that someone that has no experience with the system can find where to go. The biggest thing is it's set up in tabs, so you'll find yourself clicking through the different tabs trying to figure out, oh, is it this tab or this tab I need to hit. But after you do it about a dozen times, you figure out where everything is. And once you learn the location, everything, it really is pretty easy to navigate. So, it is going to be a big lift. It's going to be a big change. But overall, I think it's going to be a much better system for us, and you all will like it better. So Pedro, thanks again for joining us and kind of walking us through best practices for implementations. And I'm sure that we'll have more questions as more places go live. But thank you so much for joining us again.
Yeah, thanks for having me. And I look forward to meeting the rest of you guys when we're out there. And again, I can't stress it enough. When you're in front of a G2 expert, bend their ear, ask a million questions, ask them why we called it G2. Whatever that question may be, but just ask your questions so that way you feel very good and confident about what we're moving over to. The platform is very intuitive and it can be user friendly. It's just going to take a matter of time. So thanks again, Lance and Rhonda, for having me on your conference.
Perfect. Thanks again. All right, we're going to take about 3 minutes before going into the next session, and that's just an open Q&A, so make sure you ask us questions there. Melody, about the rollout schedule, we'll make sure that gets emailed out later. So if everyone just goes back out into the agenda and then go into the last session, we'll start here in a few minutes. Thank you. All right. Welcome back, everybody. Sorry about the delay, a little bit of a technical glitch, but we got it. And it happened at the end of the second day, so that's a perfect time for it to occur. All right, so this session is just an open forum to ask us questions and kind of talk about different things that are going on in the practice now. Yeah, it still doesn't look like. Do we need to go back to the other room, Brad? Okay. Let's see if we can do that. Let's go back to the other room. Yep, it's the other room. Will you send them a message?
Yeah.
All right, sorry about that, everybody. We had a little bit of technical difficulties, but that is the perfect time to have it. Is the end of the conference. So, yay! I really want to thank everybody for participating and being so engaged these past 2 days. So the point of this session is to just answer any questions that you might have for us, and go from there, and then we'll just close out the day with again rounding with the sponsors, and then we will do the grand prize drawing. So really, this is your time, with one exception, because I want to talk about one thing about McKesson Biomedical Services. But please type in questions to the chat, and we will go over them. So one quick thing about McKesson Biomedical. So a lot of you have already had the service technicians come out and look at your equipment and get that inventoried. So this was going to be a very big and robust project, but then COVID happened, like it did back in spring, and it messed up a lot of our implementation process. So the reason that we're looking at McKesson Biomedical Services is that, one, they're owned by McKesson, but two, the cost of utilizing them for not only our preventive maintenance, but also our calibrations for research compliance, the cost of that is about half of what it is for other vendors, and specifically looking at infused systems. I know many people are locked into contracts. I've been in talks with them, and it looks like they're going to release us from any obligation. I just need them to put that in writing, and then we will move out of our contracts with them and switch over to McKesson Biomedical Services. And so how they're different from infused systems is that they actually come to your site. You have to give them a space. So whether that's an exam room or a hallway or something, but they come in, they do preventive maintenance on your equipment there, so that way you don't have to send your infusion pumps in. And also with your medical equipment, they're going to calibrate that eventually. Their primary focus was getting through the Braun infusion pumps first and foremost, so that way we make sure all that's done. But now then they're going to come back and do our medical equipment. And the cool thing about that is they have a system called OneTrack where we can log everything into that, and then we can keep tabs on when our maintenance is due, when's the last time it happened. The research department loves this idea, and hopefully we can go live with it very soon. But the very first part of that is making sure that we get all of our equipment inventoried and then put all the different parts into the system, so that way we can ensure that we get everything timely and we have accurate records of everything, but then we can also look at it from a global stance. So more to come about that. It was supposed to be a very formalized, very rigorous rollout, but unfortunately that kind of got put to the side because of COVID. And now we're going to unfortunately piecemeal a little bit, but then come out with something very official afterwards. So I know that some of you have seen them or getting questions by them. They can do repairs. Their repair shop is in Garland, which is a suburb of the Dallas-Fort Worth area. And you send it in there. They have quick turnaround times. We're looking at doing a playbook for everything. So I just want to make sure that everybody knows about it and knows that there's more to come with that. So I'm trying to read through all of these questions as they're coming in. So yes, they are going to take over our calibrations and yearly audits and all of that. All of that is going to be logged into the OneTrack system, and we're getting quotes on that right now, so that way we can get that up and running. But yes, we're talking about equipment even in the exam room, thermometer scales, so on and so forth, to make sure that we're research compliant and the preventive maintenance are happening on our different pumps. So yeah, if there's any, again, going back to repairs, if there's any repairs that need to happen for the pumps, we can send those in, and that same company will do that for us. And again, they're promising quicker turnaround times and than what we're used to. And we have to see if that's true or not, but definitely looks like they're going to be a much better option for us and more cost effective as well. So as you add more pumps, we just need to make sure that we add that into the system. And so there is going to be a contact for McKesson Biomedical that will ensure that we have all of your current equipment into the one-track system. Alrighty. Trying to make sure I made it through all of these. So there was a question: can you do this after hours or on the weekends? We haven't asked them that, but that is a good question. That's something that I can talk to their field service director about and see if that maybe is a better option for some of the clinics, because it is still busy. But the good thing is that they're doing it in real time and you're not having to send off your equipment. What other questions do you have for us? Yeah. One track, again, we have to make sure that we get all of that set up. So the one track system, again, is just a kind of a repository for all of our equipment. And then from there, any preventive maintenance logs, any kind of repair logs, all of that will be housed in that system. But once we do get it up and live, there's still some contracting pieces that we have to go through with that. Once we do get up and live, then we will give people logins, the appropriate logins for it. So Laura, on that question, Laura in Waco, on that question, was that Infuse Systems or was that McKesson Biomedical that had the long turnaround? You're saying that it's been about 3 weeks and you still haven't got the pump back. Rhonda, is there anything else that you can think of that we need to talk about while we're waiting for these questions to come in? Okay. All right, Laura, with that one, please send that information to me. That's good to know. We want to make sure that they're kind of keeping their promises to us. Something they are running into, now that you say that, is that any kind of repair, they have to get approval before they do it. So make sure that you're responding to them timely to approve the repairs and get that done. So if something does have to be sent in to get repaired, then that does have to be sent into the site as it stands right now. As we look at expanding our partnership, we can see about maybe if they can open up more service sites to be more accommodating and come on site and fix things. But as it stands right now, the service center will stay in Garland and things will be fixed there. Oh, yes. Also remember, there is a post-conference survey. We would love to hear your feedback. We want to hear your feedback. We know that this virtual format, which has been great, honestly, I think that this has come off very well. We all know that we prefer to see each other in person, but we still want to make sure that you're getting the information out of these meetings that you need and want. And so please, before the end of the day, go into the help center, and I think it's the lower right-hand box. It's complete conference survey. Please take a few minutes to do that for us. That would be very helpful. All right, more questions coming in. So if you're looking at ordering more infusion pumps, if you truly need a new infusion pump, if one breaks and you need it, I would do that. But I would say let's hold off on ordering a lot more, and we can talk offline about that, because to see what your true need is and why you need it. Because I don't want you ordering too many for potential reasons later on. But if you truly need something right now, don't hesitate to get it. All right. So a couple different experiences with McKesson Biomedical. Irving, it took about a week to get everything done, and then Southwest Fort Worth, it took a couple hours. So this is good feedback. We need to hear about this, and those sites that everything worked well on, that's great, and you have a good impression of them. And those sites that it didn't go well, then we need to make sure they know about that, so that way your next experience and future experiences can be good for everybody. So sorry about those people that it maybe took a little longer than necessary, but it sounds like a couple of their sites, they performed exactly like they said they would. Yeah. So a couple of people said that there was upstream occlusions on pumps that were serviced. So we're going to ask them about that and see if that's an issue. We also need to see, are those some of the original pumps that were reordered back in 2011, 2012, because we know they were coming up on the 8 to 10 year mark for some of those. And are those ones that we potentially need to get new ones of? I don't know why the stream's not going. I have to scroll down for everything. Yeah, report turnaround. We need to figure out what that really looks like, and I'll reach out to David and see where that's housed. That could be housed on one track, and maybe they just don't realize we don't have access to it yet. But that's part of the beauty of it, of the one track system, and using McKesson Biomedical, is that everything is housed there because it is kind of our repository for all that. All right. What else? What other questions do you have, even outside of McKesson Biomedical? Anything? Would like to ask of us while you have some time? All right. Oh, yes, the recorded session. So this, you all will have access, and anyone that has a registration link will have access to this platform for roughly 90 days. So you can click on the different sessions and replay it. I know I clicked on one this morning and it replayed the whole day in the first session. So I don't know if they're going to chop it up into each session is going to be replayable, or if it's going to be the full day. We'll see what that looks like after everything wraps up. But yes, you will have access to this for 90 days. And then we're also going to put all the PowerPoint presentations that everyone presented onto SharePoint for you all on the nursing page. So if you have pumps that need to be repaired, and you're still active in your Infuse system contracts and you need it right now, you can go ahead and do that. But if something comes up later on down the road, then we're going to start sending that to McKesson Biomedical. The post survey, if you click on the top part of the screen under Help Center, and then another window will pop up, and I think it's like 4 boxes, and the lower right hand box is the post survey link. So Trudy, yes, if you need pumps right now, if ones are broke, or you have ones that are broken and you need them, go ahead and order them. But if those people that wanted to do a full overhaul of their infusion room and do all new pumps, then that's where I'm saying kind of hold off. Like if you're in a deficit and you need one, go ahead and do it. Just don't do the full meal deal with it right now. So, Laura, your question about the infusion nurse that has less than 2 years experience but did have some chemo admin. I always question of where did they get that chemo admin experience, because if it was in the hospital, and yours might be a little bit different with MD Anderson in your backyard, if they had extensive chemo experience, then I would go ahead and move them up to the just the normal chemotherapy biotherapy class. But if they were in a typical hospital oncology unit that maybe only does a couple of treatments every week or a day, then I would start them off with the fundamentals and just make sure you have that all under their belt. And then after that next year, a couple years, move them up to the normal ONS biotherapy chemotherapy class. Okay, well, it looks like the questions have slowed down. Again, I want to thank you, everybody. I know that this year has been very difficult and not what we all envisioned us doing for 2020, but it is what it is. But you all done a great job. Thank you so much for participating in this meeting, in this conference. Please do the post survey. Please go and round with the different vendors and sponsors. We'll do the grand prize drawing, and then we will be all done for today. Perfect. Kathy, just real quick, the assessment checklist, I don't believe we have that anywhere, but I'll look for it. But that would be a good idea to have and make sure that we have that available for everybody. Laura, the stem cell transplant unit, she might have had a chemotherapy. Well, we can talk about that more offline, but I'm leaning more towards fundamentals, but we can talk about it more. All right. Perfect. All right. Have a great weekend, everybody. Thanks so much. Bye. All right, everybody. So, passport to prizes, grand prize time. It looks like our winner is Cassidy Davis at the Denton Cancer Center. Congratulations on your brand new iPad. I will reach out to you offline and make sure that we get that new iPad to you. Congratulations. And I want to thank everybody for participating and rounding with our different sponsors and vendors. They very much appreciated it. I've been getting messages all day yesterday and today, and I hope you found this to be fun and interactive and learn a few things. And please make sure to go take the post-conference survey to let us know how we did and how we can improve other things. Obviously, we know that we would all prefer to see each other's faces, but we want to make sure the content is still very relevant and pertinent to you guys. So on behalf of myself, Stephanie, and Rhonda, thank you so much for being here, for doing what you do each and every day. And we look forward to seeing you one day in person again very soon. Thank you.